Hello, ma'am.
Yeah.
Yeah,
Can
hi.
we start, Sayan?
Madam, we are going live. Just give me 30 seconds. Yes, so we are live. We are live, madam. I'll just share my screen. Once again, good evening to every one of you, respected faculties and delegates. I cordially invite you to this webinar by Public Awareness Committee FOXY, and along with that, in association with the PPH Committee FIGO and WATOG. And also, it's my pleasure to once again introduce Dr. Monica Umardat, who is the PAC Committee Chairperson AMOX for 2022.
That's okay, Sayan. Let it be. Thank you so much for your kind introduction. A very warm welcome and good evening to all the esteemed faculty members. We welcome you to the 21st episode of the Public Awareness Committee webinar today. And the icing on the cake is that it is associated with the PPH Committee, FIGO, as well as WATOG. And we have the who's who of both the associations today with us. I invite all the esteemed faculty members to join us today for the lighting ceremony. Can we have the inauguration slide, please, Sayan? The next slide, please, Sayan.
Yes, madam. Just a minute. It's not changing.
You have paused it. Thank you, Sayan. It is my proud privilege to introduce Dr. Priyanka Roy, the chairperson of the Public Awareness Committee and President WATOG, who is the brainchild behind this webinar. I welcome him to introduce you to the program as well as invite all the faculty members. Over to you, Dr. Priyanka.
Yeah, thank you so much, Monica. It gives me immense pleasure again to welcome all of you to this webinar. Of course, the think tank of FOXY, FIGO, as well as WATOG. So I would like to welcome our respected President, Dr. Jaideep Tang sir, Secretary Madhuri ma'am, and thank Dr. Ajay Mane sir for always blessing the program and being present here as well. And Dr. Parikshit Tang sir, who is the treasurer of FOXY. FIGO front, I would like to welcome Dr. Ankiara ma'am, Dr. Ravi Chandran sir, the secretary, Dr. Edgar, the vice president, and Dr. Shanta Kumari ma'am, who is the treasurer. And WATOG, I would like to welcome Dr. May, the secretary, Dr. Akinene, who will be present today as a chairperson, and Dr. Catherine, who is the treasurer. It gives me indeed a lot of pleasure to welcome my coordinators who have worked very hard for this program, Dr. Monica, Dr. Shatabdi, and we are going to introduce two new faces today, Dr. Atalia, who is the social media in charge, and Dr. Madhumita, who is the PSC publication in charge. Our conveners, Dr. Bharti Rajshekar ma'am and Dr. Raghavendra sir, have done brilliant work. They're the South Zone conveners and have done brilliant work in coordinating the South Zone webinars. Today, we have our chief guest, Dr. Jaideep Tang sir, with us. Thank you, sir, for joining us. We have a guest of honors, Dr. Rishikesh Pai sir, Dr. Hima Devakar ma'am, and Dr. Nandita ma'am. Thank you for giving a valuable time for us, and it means a lot to all of us. This time we did plan to do a PPH poster competition, and we were very excited to receive almost, I think, more than 70 plus posters that we have received. And it was a hard time for our judges, Dr. Ajay Mane and Dr. Preeti Kumar, to judge them. And they have come out with the results, which we will want to declare in this session as well. We all know that cervical cancer is a disease that can be prevented. And we wanted to release a video on cervical cancer that is on behalf of the PSC through a presidential endeavor. We wanted to do a video which which are pledged from the gynecologist per se of the country to do at least a per speculum examination after 35 years of age. We know that we should routinely do it, but somehow we are not clinically examining the patients so very well now, and that's why the request, and that's why most of us have pledged for it, a per speculum examination for all women visiting us in the OPD after 35, and we have done a video for the same, which we will be releasing today as well. I would like to welcome our esteemed speakers, Dr. Jolly. Thank you so much for joining us. She is the chair of the FIGO PPH committee, and also Dr. Muralidhar Pai sir, who is also extremely busy, Dean of Sikkim Manipal Institute. And our chairpersons, again, two very eminent persons, Dr. Jaideep Malhotra ma'am and Dr. Ajay Mane sir. And I would also like to welcome my friend Dr. Akinene, who is the vice president of VATOG as well. We have an excellent panel to be moderated by Dr. Sheila Mane ma'am, Dr. Aruna Suman ma'am, and our expert is Dr. Ferdowsi Begum ma'am from Bangladesh. Panelists today we have Dr. Varsha Lahade, Dr. Bharti Rajshekhar ma'am, Dr. Raghavendra Prasad, Dr. Radha Madhvi ma'am, Dr. Nirmala Devi, Dr. Chandra Ponuswamy, Dr. Lohita, Dr. Manjula Rangunathan, and Dr. Mangala Gadwal, and of course Dr. Arnav, who will be the India representative for VATOG. So thank you so much, all of you, for joining us. I would like to welcome all of you, and first of all, to take a welcome address from our chief guest, I would like to welcome Dr. Jaideep Tang sir. So can I have Dr. Jaideep Tang sir CV, please? Yeah. So to formally introduce Dr. Jaideep Tang sir, he is, of course, the president of FOGSI. He has been the chair. He's the chair of the Young Gynecologist Association, or YGA, of committee of AOFOG. He's a project lead FOGSI USAID project. So he was the Secretary General of FOGSI and awarded the honoraris causa FRCOG. He is the past president of MOGS, and to say in short, ever smiling and always supportive. So I welcome you, sir, to this platform to say a few words of blessings to everyone.
Thank you very much, Priyankur. It's always a pleasure to be a part of anything which Priyankur organizes and puts together. I remember in the COVID time, he was doing so much work that I used to call him national coordinator, because whatever was happening in the nation, he seemed to be coordinating. So congratulations, Priyankur, for putting this together. Priyankur, can you remove the slides so that I can see everyone?
Can you please
stop sharing?
Yeah. So let me also acknowledge the fact that this is a partnership, and I have always felt that partnerships are the lifeblood of organizations. They bring so many synergies, and they bring so many advantages to each and every organization, where every organization can identify the strength and fill the gaps in organizations through synergies. It's wonderful that there is a FIGO and a VATOG partnership here, and I'd like to thank and acknowledge the office bearers of FIGO, Dr. Ann Kiara, Ravi, Edgar, and Dr. Shantakumari, and of course Dr. Rishikesh Pai, who is our AOFOG trustee to the board of FIGO, and VATOG led by Dr. Priyankur Roy, Dr. Ang, Dr. Ubam, and Dr. Lizette. And of course, the office bearers of FOGSI, Dr. Madhuri Patel, the Secretary General, Ajay, the Vice President in charge of this committee, Parikshit, the Treasurer, and all the other office bearers. Congratulations to the coordinators. Monica, I think, has just finished as chair of the PAC committee of MOGS, and she has hit the ground running in her new roles. Dr. Day, Dr. Shajan, and Dr. Madhumita. I think Dr. Madhumita was recently involved with some activity of the Midlife Committee, where a publication had come out, and the conveners, Dr. Bharti and Dr. Prasad. It is, of course, a pleasure and a privilege to share a platform with the guests of honor, the immediate past president, my dear friend Rishikesh, Dr. Hima Devakar Madam, the dynamo of FOGSI, and what I've always said, president with the golden touch, Dr. Nandita Palshetkar. I can see, I think Nandita and Rishikesh are probably at the airport somewhere, waiting to catch a flight. And of course, Priyankur, you put together a very nice program with the declaration of results with Ajay and Preeti, release of the video, and wonderful speakers, Dr. Jolly, whom we had the pleasure of meeting recently at the AICOG in Hyderabad, along with chairpersons, my elder sister and namesake, Dr. Jaideep Malhotra, and Priyankur, and Dr. Pai, and chairpersons Ajay and Dr. Ubom, and of course, a glittering panel, if I may say so, with a galaxy of stars, with moderators Dr. Sheila, Dr. Aruna, expert Dr. Firdausi, and all the panelists, Varsha, Bharti, Dr. Prasad, Arnav, welcome to
Hi,
Foxy
sir.
the Way if you
Welcome.
haven't
Thank
been
you.
here before. Dr. Radha, Dr. Mangala, Dr. Manjula, Dr. Lohita, Dr. Punnasamy, and Dr. Nirmala. So congratulations, Priyanka, on this wonderful initiative, and keep up the good work. And we hope more and more activities will emerge from the PAC committee. Thank you very much.
Thank you so much, sir, for this encouragement to all. It means a lot to all of us. And now we, of course, have our esteemed guest of honors as well with us. So, Jaideep sir, thank you. And we will take blessings from the guest of honors as well. And after that, we have the declaration of results for the PPH poster, and we would request you to kindly stay on for some more time. So I hand over the session to Dr. Monica to kindly take us through the guest of honors, please.
Thank you, Dr. Priyankur. It is my proud privilege to introduce our guest of honor for today, our immediate past president, Rishikesh Pai sir, who has been ever encouraging to all of us. He remembers all of us by our names and the activities that we have done. Thank you so much, sir. He has been the administrator at the Foxy Manyata Initiative as well as the director of the corporate affairs of the IFFS. He is also the treasurer at FIGO. We welcome you, sir, and invite you to give your blessings for the program, sir.
Just to add on a point, he is also the Asia representative to FIGO currently. Asia, the council member, council member to from the Asia zone, trustee from the Asia zone. Sorry, sir. Yes, sir. Thank you so much for joining us.
So thank you, Priyankar, and would like to first pay my respects to all the senior people who are there here. Dr. Jaideep Tang, our president, and the 3-4 presidents who are also there, Hema Diwakar, our previous president, Dr. Nandita Palshetkar, and Dr. Jaideep Malhotra, who is also our previous president. And Priyankar, we are proud of you that you have now become the VATOC president, one of the youngest from India to become the VATOC president. And of course, this is jointly done by the 3 organizations, that is the Foxy, represented by Jaideep, Dr. Madhuri, Dr. Ajay Mane, and Dr. Parikshit Tang. FIGO, of course, my boss, Dr. Anki Ahara, Ravi Chandran, our Secretary General, Edgar, our Vice President, and Shanta Kumari, our Treasurer. I am the trustee of the Asia-Oceania region. We have 5 regions of FIGO, and one of the Asian region is represented by me. And then the VATOC is also there. Priyankur is our president. Then Dr. Ng is there, who is the secretary. And then Dr. Ubom, who is our vice president, and Catherine, who is our treasurer of VATOC. And now Arnav has come in as a representative for India, so I'm really happy for him. And then Monica Oberman, who has really been a very dynamic person. She has been, Priyankur, she is a real support structure for you, along with Shatabdi, Atulya, Madhumita, Bharti, and Raghavendra. So it's a great team. And then our Dr. Preeti Kumar is also there, and Murlidhar Pai, and of course our very famous Dr. Jolly Beza, who is going to join us. So anyway, what I was saying is that, can you hear me well?
Yes, sir.
So what I was saying is that PPH is very important part for all of us. Foxy has done a lot of work in PPH, and I was the fortunate to be called for the PPH WHO meeting in Dubai when I was president, and we had a fantastic document that has been now released, and a lot of milestones have been set for the PPH document. We also have done a lot of work at the FIGO level also. We have the 2 ongoing FIGO program going on, Ampli PPH program, which is led by Nandita and Shanta, and the LDI program that is led by me and Madhuri. And Jaideep, of course, is there all the time, and he's come out with a very big Gates Foundation program, which I'm sure will have a lot of PPH components. So India is very active. We have a committee, and Preeti also has done a lot of work on PPH when she was the chairman of the committee. And Sheila Mane, I think I've missed out on Sheila Mane. She's there also. And Sheila Mane is also done very active. Aruna Suman, Dr. Firdausi Begum, also our neighbor, is also there. So a lot of work has been done. I don't want to take much time because you have a lot of good speakers ahead. And so we'll try to keep on lowering the incidence of PPH. The FIGO is after our blood. The LDA program is very aggressively implemented. We have to file reports all the time. And a lot of leaders, nearly 51 leaders have been identified. And we have 4 centers that are especially active in UP and Bihar, which are, the ones which have been selected to demonstrate the decrease in PPH by implementing various interventions. And I hope that this program will, then be amplified and extended to other parts of the country, and we can collectively decrease the incidence of PPH and, of course, bring down the maternal mortality. So I would like to thank you all again. And before I leave, I would like to remind you that we have a very exciting conference of AOFOG. We are member of AOFOG. Of course, Jaideep Tang will tell you that, which is in Busan. And I'm happy to inform you that the regional meeting of the FIGO for this year, last meeting or regional meeting was in Cartagena. That regional meeting is in Bali from the 24th to the 29th of November. Along with Ravi Chandran, in charge of the meeting. Budi Vivek, our colleague from Indonesia, will be. That another meeting is coming up, an international meeting. Of course, after we attend, all of us attend our president's primary or premier meeting, which will be there in November mid. So we can attend that meeting, and then all of us can go to the Indonesia meeting in Bali. So I would like to thank you all and looking forward to a great interaction. And before I sign out, Nandita is there. I'm sure she'll talk about it. Our AICOG meeting, which is there and which is going to be there. And you please block your dates. Dr. Jaideep Tang and Dr. Sunita will be there to invite you, along with Dr. Nandita, myself, Niranjan, and all our vice chairmen and vice presidents, all of them, Dr. Rishma, Dr. Noza, Dr. Suvarna, all of them are there along with the whole team. So we are looking forward to a fantastic interaction with you in January of 2025. So I think I will thank the organizers, especially Priyankur, for inviting me. And I'm sure Hema and Nandita will throw great light on PPH. Thank you.
Thank you so much, sir. It is also an honor to introduce our next guest of honor, Dr. Hema Divakar, Madam. She is also the past president of FOXI, and she's the divisional chair of FIGO. She is also the medical director at the Divakar Specialty Hospital. She is the dean at the KCOG College, the CEO and chairman of the Artist Association, that is the Asian Research and Training Institute for Skill Transfer. We welcome you, ma'am, and we invite you to please give blessings to this webinar.
Thank you very much.
Currently, she's a divisional chair in FIGO as well. So congratulations for that, ma'am.
Thank you. Thank you so much. Can we move the slide off? Thank you so much. So Monica, Priyankur, and the Young Turks leading the show. Congratulations for getting all of us together. And I would start like out of the box. Pai has told that Nandita and myself will throw light on PPH. Okay. And I would start by saying that every pie matters. Why? Because we start the PPH care in a preventive manner from the anemia care. And what did Pai do during his tenure? Many, many clones of him all over the country, anemia here, anemia there. Everyone got buzzing with the movement of Anemia Hatao or Nana anemia, and then to bring the badlao. That is the start point, because the FIGO believes in the life course approach and preparedness. PPH, we say prepare, prevent, and handle. So to prepare, you should not do a knee jerk only when she gets pregnant and then she's delivering and then she's losing blood and she's losing her life. No, we have to gear up ourselves well before that in the preventive care and seeing to it that 12 by 12 program of FOXI long ago, every girl of 12 should have 12-gram hemoglobin. So from there, the journey begins of the PPH care. So that is one of the most important components to carry on the movement brought in by our leadership from our parent organization, Foxy, and the FIGO has paid a lot of attention to our highly bustling initiatives and wants to join forces with us. And then prevention, this is the preparedness. The prevention is by active management of third stage of labor. And what did our Manyata experience show us? That active management of third stage of labor or such preventive methodologies, they scored only 20 marks. Whereas management of complications of PPH, they got 80 marks because nobody was doing the basics and then everybody got into trouble and then they were trying to then grapple with that. They were experts at that. So we need to focus and invest our attention into preventive and the preparedness, carrying on with the preventive care, inclusive of our Manyata experience, which has shown us that readiness is the key. And every labor room has now the PPH dabba, as we call it, the box which is prepared, and they need not run here and there to fetch the things. Every single frontline healthcare providers has vouched for the fact that this small change has brought in so much difference to the management. And of course, lastly, it's inevitable, man proposes, God disposes. Despite doing everything, the lady lands up into PPH. Anybody can land up into PPH out of the blue. And then you have to muster your presence of mind in that golden hour to handle it to the best of your capacity. So this journey is long, and it's the life course approach from the Well Women Healthcare Committee. We produced the famous Wellness on Wheels, the FIGO Wellness Wheel, throughout the life courses, always in the concept of ekikaran or integration. Again, we go back to the Jivanasya Vrittam of the life cycle pledged by our present president, Dr. Jaydeep Tank, that we need to connect the dots. We need to put our act together in the best possible way. And I think this seminar is yet again one such brilliant attempt to get the best of the people on board. So I'm sure that the delegates will have a golden experience managing and paying attention to what they should be doing, using both their knowledge, skills, and wisdom to handle PPH, to which now Nandita, my very, very beloved friend, will add more light to the situation, because she leads the FIGO PPH Ampli initiative, and there is ample opportunities for each one of us to join forces, use our synergies to the best of our capacities to do the best for every girl, every woman, everywhere across the globe. So thank you very much for Monica forcing me to come. I said, why you want chief guest? 3 guests of honor. She said, no, ma'am, you have to come. So I'm here. Thank you so much. Namaste.
Thank you so much, ma'am, for enlightening us and for giving us an entire picture. Thank you so much for being there with us today. I invite Dr. Nandita Palshetkar, madam, today. She has been the past president of Foxy, as well as the past president of AMOX. She has many accolades to it. She is currently the Foxy representative to FIGO, and she has been there wherever you have been asking for. She's also the past president of ESAR. We welcome you, ma'am.
And also to add on, she's currently heading the FIGO project for Ampli, the PPH project. So thank you so much, ma'am, for joining us in spite of being in the airport. So thank you, ma'am, for that.
No. Thank you, Priyankar. Thank you, Monica. I think it's always a pleasure, and I cannot refuse requests from both of y'all. It's impossible. And I want to congratulate Jaydeep that his year is rocking. Everybody is all fired and doing all the work. So I'm not going to take everybody's names, but as Rishikesh said that me and Hema have to talk about PPH, and I think Jaydeep will also talk about it. But what I want to talk about is the PPH Ampli project, which the FIGO has given us. This is about creating data, awareness also. So we have taken 2 states. One is Maharashtra, where the MMR is really reasonable and low. We've in fact crossed the SDG goal. And the other state is Madhya Pradesh. So the learnings from these 2 states are very, very important. Even in Maharashtra, there are places where we are conducting is Jalgaon and Nandurbar. And in Madhya Pradesh, it's Vidisha and Khargaon. Now, these are the places which are very difficult to reach. They are tribal areas. In fact, there is no ambulance which can reach over here. And women come on bambulance. They're actually in bamboo stretchers and they are bought there. So I think the whole object of the PPA Champley project is to prevent the preventable. And we've really concentrated on awareness about 3 drugs: carbetocin, tranexamic acid, and misoprostol, and how that can be utilized in different settings. Misoprostol can be self-administered by the woman. So in areas where one cannot reach the hospital or anything, the local NGOs, we are not targeting. Jhpiego is not going by itself, but we have patched up with the local NGOs where they will administer this drug. Tranexamic acid, of course, is something that has helped us so many times, but the awareness needs to reach each and every person. And the FIGO guidelines also now have tranexamic acid as in the emotive bundle, and carbetocin, especially in places where electricity is a problem. I think the heat stable carbetocin is really a boon. So these 3 are the pillars of the PPA Champley group, PPA Champley project, and that is what we are trying to create awareness. And now we have extended the learnings. As Hema said, Manyata, we've learned a lot. Even from our project of PPA Champley, we are supposed to spread the learnings to Nepal, Bangladesh, and Sri Lanka. And 2 other states have been selected, Orissa and and Uttar Pradesh. So I think this is something that will really help bring the MMR further down in those states where it is a problem. So Priyankur, Monica, thank you very much for inviting me here, and all the best. And I'm sure the sessions will be fabulous. And also cervical cancer, I must mention here that India has taken such a bold step in giving, the vaccine to all the adolescents of our country. I think that's amazing, and it will go a long way in making it one of the lowest incidences in our country, because it's the largest killer in our country. So I think you've chosen 2 fabulous topics, and I'm really happy. And congratulations, Priyankur, on that of presidency. Thank you.
Thank you so much, ma'am. It is indeed a pleasure to have all of you. Especially like to thank Jaideep Tang sir, Rishikesh Pai sir, Hema Divakar ma'am, and Nandita Palshetkar ma'am. I would say mentors for all of us juniors who are present over here, and you guys have really given us the platform to at least visualize what at one point of time we could probably do, because you have given us so many opportunities. So thank you so much to the 4 of you for always supporting us in all our endeavors. Thank you once again for
All the
being
best.
here. Thank you so much, sir. Thank you so much for everything. And we will now go to the declaration of the PPH poster results. We have with us Dr. Ajay Mane, sir, who I always say is, can we have his CV, or Monica can introduce sir, I guess. So yeah, just to say, so Ajay Mane, sir, I always tell him he's been the silent vice president who has supported us silently in everything that we do. He has been a thorough support for us in all our activities and never have questioned us for anything, but he has been a sole support backing us for all that we do. So thank you so much, sir, for joining us. Thank you for going through all the PPH posters. Thank you for judging them. And I would request you, I mean, the number was quite a lot. I mean, it was almost 70. First scrutinized, then the second list. Ajay, sir, I would request you to kindly declare the results of the poster presentation for the competition. And just to introduce, of course, he's the vice president of Foxy and mainly the medical legal consultant who has done all the medical legal consultations free of cost. He has been the immediate past joint secretary of AMOX as well. So I welcome sir to the platform to kindly declare the results. And I also would like to thank Preeti ma'am, who has also done a lot of the judgment thing, but she could not be present today. So thank you, Preeti ma'am, for all the efforts that you do for us and for Foxy per se. Ajay sir, over to you.
Thank you, my younger brother Priyankur. And whatever you said is not correct. You all are so much active that I must say yes to your all projects. That's the basic thing behind this. So if Priyankur says anything, I need to say yes, because he is always correct. Then Monica, if she says something, I need to say yes. So all my chairperson, they are excellent. So my job is to say only yes and yes. That's why I am very fortunate to have such chairpersons. So I'm here to Okay, respected Rishikesh sir, Bharti ma'am, Aruna ji. Arno, first time I'm seeing Arno. Congratulations and welcome Arno here for the webinar. Very nice thing. Priyankur,
Thank you,
respected
sir.
Hema,
Thank you.
yeah, respected Hema ma'am and respected Nandita ma'am. I think everybody is on the airport. Three of them are airport. Respected Jaideep ma'am. So and Jaideep sir, Madhuri ma'am, Parikshit, and then our Dr. N, Dr. Ravi, Dr. Edgar, Dr. Shanta Kumari ma'am. Then from VATOG, our Priyankur, Dr. Mai, Dr. Obam, and Dr. Catherine. So I'm here to declare the results. I'll just pronounce the names. By names, the paper came to us. So here is the result. The first prize goes to Dr. Sai Sarvajna and Dr. Jasmine Begum. First prize.
Sam, Sam, can we have the slides that you prepared, please, with the posters?
Yeah, Monica, can we show that?
Yes, ma'am.
Yes,
Yes, sir. Yes, sir.
ma'am.
Definitely.
Just give me a
Then
minute.
can we have the slides, please, of the results?
Yes, just give me a minute, madam. I'll just see.
Sir, we know it was a very difficult task for both of you to go through so many posters.
Oh, Preeti is busy with the emergency. She has given me the task to declare. Basic work is done by Preeti only. She is very active. She has scrutinized everything.
Yes. First of all, sir, we would like to congratulate all the participants of the poster competition, and we would give all of them a participation certificate. And we also would like to acknowledge Corona Remedies here, sir, because they always give a prize to the winners, sir. We have a watch and a Doppler machine which goes to the winners, sir, which is sponsored by Corona Remedies, sir. So I now request you to please declare the third prize first. Can we have the slide, please, Sayan? Yeah.
Okay, he has started from third prize. Okay, fine.
Yes, sir.
Third prize goes to Dr. Aditi Ramugude and Dr. Amarjit from Mumbai. LTMMC and Sion Hospital, Mumbai.
Yeah.
Aditi Ramugude. Then the second
next slide,
prize,
please.
congratulations. Then second prize goes to hello.
Yeah. Ajay sir, can you see the slide now?
Second prize Dr. Nancy
Sayan,
J.
can you mute
Nakata.
everybody else except for Ajay sir so that he can speak?
Yeah, Dr. Nancy J. Nakata.
Madam, is this slides visible?
Yeah, it is visible to me, sir.
It is seen.
Can we request Dr. Lohita to kindly mute yourself? Dr. Lohita, can you please mute yourself?
Or else our
Thank you,
admin
sir.
can mute.
I have
Yes,
done it,
muted,
sir.
sir. Please go on.
Yes, sir.
Fine, thank you. And now the first prize. Next slide, please. Yeah, first prize goes to Dr. Sai Sarvajna and Dr. Jasmine Begum, Bhubaneswar AIMS. So congratulations all winners and congratulations to all participants also, because participation is as equally important as the winning. Okay, so never mind, next time we'll be having another quizzes and another competitions day by day, because the chairpersons are very active. So congratulations to winners and best luck to others. Thank you, Priyankur, and thank you, Monica ji, for giving us the chance. Thank you very much.
Thank you, Ajay sir. Yes. Priyankur, can you brief about the initiative that we have taken for the cervical video, and so that we can then start showing the video? This was
Monica, I think
yes.
the best person to talk about this video is you, because it was your brainchild and you brought it out and you wanted this thing to be out. So I think if you brief it and we'll go on with it. No problem. Thank you so much. And thank you for the initiative as well. So it was a wonderful initiative on the World Cancer Day. There is a per speculum examination, at least for all women after 35 years of age. Monica will brief you and we'll just show the video of the enthusiasm and the active participation of the Foxians.
Thank you, Dr. Priyankur. On the 4th of February, on the occasion of World Cancer Day, we at least wanted all the Foxians to be socially so aware that at least they do a per speculum examination to pick up any lesion that can be seen on a speculum examination, and at least do a visual inspection of the cervix so that we pick up the cases earlier. The earlier we detect, the better is the treatment part, the more is the conservative treatment that we can offer to a lady, and more is the survival rate. This was our aim in bringing about this video. As soon as we circulated the flyer, we had lots and lots of videos which started pouring in from all the corners around India, but we could not accommodate everybody. However, we have tried to accommodate the most of the videos which we have received, and it is a 6-minute long video dedicated to the enthusiasm of all the Foxy members. And I thank Dr. Atulya Shazin, who will be the social media in charge for the Public Awareness Committee, for compiling this video. And Atulya, it is a great honor to have you on board with us with the Public Awareness Committee. I request Sayan to please play the video today now.
And before you do that,
just pause.
before you do that, we will also like to introduce Dr. Madhumita. As Jaideep sir already mentioned, she is actively involved with the sexual of the midlife management committee as well, and she has gleefully taken up the pleasure of associating with us as the publication in charge for the PSC as well. So thank you so much, Dr. Madhumita. She happens to be my senior in college as well. So thank you for being here and thank you for joining the committee.
Thank you so much, Roy. Thank you for having me on board. Lovely to be associated with you. Thank you, Roy. Thank you.
Thank you. We'll go on with the video, please.
Cervical cancer, as we all know, is one of the most preventable cancers in a woman's life. So we need to understand that for prevention of cervical cancer, there are a few detection techniques which are foolproof and can be done for betterment of women's health. So for that, we from the Public Awareness Committee has taken up this initiative of a pledge from all the healthcare workers, gynecologists per se, all Foxians, that we will test all women, at least do a per speculum examination for all women after the age of 35 years. Per speculum examination should be a must. If possible, of course, in addition to that, VIA or a colposcopy if possible. And we know that cervical cancer vaccination is quite very helpful in preventing this cervical cancer, and that is why I think we should do the examination first. Thank you.
I am Dr. Rita Mishra, and today on World Cancer Day, I take a place as a responsible citizen and gynecologist that I will do the per speculum examination of each and every woman who is attending my OPD, and that is above 35 years of age. We have to defeat the cervical cancer and other cancers also. Thank you.
And I pledge to do a per speculum examination for any woman above 35 years of age in my OPD.
I pledge to do per speculum examination of every woman above 35 years of age in my OPD.
I pledge to do a per speculum examination of all patients above 35 in my OPD.
I, Dr. Vidya Ambore, pledge to do a per speculum examination of every woman above 35 years of age in my OPD.
I pledge to do a per speculum examination of every woman above 35 years of age in my OPD.
On the occasion of World Cancer Day, I pledge to do per speculum examination of every woman who is over the age of 35 years. Thank you.
I pledge to do a per speculum examination of every woman above 35 years of age in my OPD.
I, Dr. Shashibala Bhosle, take the pledge to examine every female more than 35 years in my OPD by per speculum examination to eradicate cancer cervix. Thank you.
I pledge to do a per speculum examination for every woman above the age of 35 years in my OPD.
I pledge to do a per speculum examination of every woman above 35 years of age in my OPD.
To do a per speculum examination of every woman of age above 35 years in my OPD.
I will do a per speculum examination for all the women who come to my OPD, and I've always been doing it and I shall continue to do so.
Dr. Rekha Singhal, I please to do a per speculum examination of every woman above 35 years of age in my OPD.
I pledge to do per speculum examination in every woman
in my OPD.
Close the care gap is the theme of World Cancer Day 2024. I pledge to do a perspective examination of every woman who is more than 35 years of age and is coming to my OPD.
I, Dr. Veera Lohia, pledge to do first speculum examination of every woman above 35 years of age to help in preventing cervical cancer.
I pledge to do per speculum examination of every woman above 35 years in my OPD.
To do per speculum examination of every woman above 45 years of age in my OP department.
Myself, Dr. Sunita Agarwal, I take place to examine every woman who is above 35 years per speculum examination to eradicate cervical cancer on this World Cancer Day. Thank you.
I take a pledge that I will examine every woman in my OPD who is more than 35 years of age by per speculum examination.
On the occasion of World Cancer Day, I, Dr. Taru Chhaya, pledge this: all patients above 35 years of age I will examine per speculum always as usual.
World Cancer Day, I, Dr. Kanchan Batra, pledge to do per speculum examination of every woman above 35 years age in my OPD to prevent cervical cancer.
Dr. Kumar Gupta take pledge to do per speculum examination of every woman above 35 years of age in my OPD. Thank you.
I take the pledge of that I will examine every woman more than 35 years of age by per speculum examination, so to prevent cancer cervix.
I take pledge of examining each and every woman above 35 years of age by per speculum so that we can diagnose cervical cancer as early as possible.
I am taking pledge to do per speculum examination of each and every patient who is 35 years and above coming to my OPD.
I will do per speculum examination of all the patients above 35 years coming to the OPD and will help to prevent cancer cervix. Thank you.
I, Dr. Monica Gupta, on World Cancer Day, take pledge to do per speculum examination of every woman coming above 35.
I pledge to do a per speculum examination of each and every patient above 35 years of age in my OPD.
Take pledge that I will do per speculum examination for every woman who is more than 35 years old and coming in my OPD. Thank you.
Thank you so much for an overzealous response to this initiative by the Public Awareness Committee. Thank you to everybody who has participated. Can we stop sharing the slides, Sayan, and can we have the CVs of the chairpersons of the next academic session? I declare that the inaugural session is over, and I request Dr. Priyankur to please give the vote of thanks for the inaugural session.
We'll move on with the scientific. The video was long, but I thank all of you for being there, for listening through it, and it shows the effort that came in had to be displayed, and that's why we wanted to display the whole thing. There are a lot of other videos. Thank you so much once again, all of you, for joining. I will not Deep sir, Rishikesh sir, Hema ma'am, Nandita ma'am, and of course Ajay sir for being here and for being with us for the whole session. Thank you so much once again.
Thank you, Dr. Priyankur. We now move on to the next academic session. The first session is the talk by Dr. Jolly, which is a FIGO session. I invite the chairpersons for this session, Dr. Jaideep Malhotra madam and Dr. Priyankur. Dr. Priyankur has been introduced in the inaugural session. I would like to introduce Jaideep madam right now. Can we have the slide, please? Yeah. She is the Managing Director of ART Rainbow IVF. She has been the past president of FOXI, the chair of the FIGO Committee of the Reproductive Endocrinology and Infertility. She is also the Regional Director of the South Asia Ian General School of Ultrasound, the professor at the Dubrovnik International University, Croatia, and the past member of the FIGO working group on RDEH. We welcome you, ma'am. I request Dr. Priyankur to introduce Dr. Jolly and Jaideep Malhotra, madam, to please conclude the talk after ma'am finishes.
Thank you so much, Monica. First of all, before introducing Jolly ma'am, I would like to talk just one line about my co-chair, that is Jaideep Malhotra ma'am. And thank you so much, ma'am. It was by holding your hand that I got into VETOG. And thank you so much, ma'am, for coming here. And the first person when I thought of for this webinar was you, ma'am. Thank you for joining today and giving me the opportunity to co-chair along with you, ma'am. Thank you once again, ma'am.
Thank you. Thank you.
Thanks so much, ma'am. I would now like to introduce our speaker for today, Dr. Jolly. Dr. Jolly is currently the chair of the FIGO Childbirth and PPH Committee. She was the chair of FIGO PPH Working Group, was a member of FIGO Committee for Ethical and Professional Aspects of Human Reproduction and Women's Health. She is, of course, a renowned gynecologist in Uganda. And the best part with her is that she is, even in the fact that we are juniors, we are trainees, she is the one who takes the initiatives and always reminds us how far have you gone in doing this initiative. And that's the best part with Dr. Jolly. Dr. Jolly, it's always a pleasure working with you, and I'm sure it will be a pleasure for everyone present here to listen to your talk today. I hand over the session to you to kindly deliver your talk, which I'm sure will be a very, very informative session for everyone present over here. So Dr. Jolly, over to you. And I'm sure the talk on multiple steps, multiple bundles in management of PPH will enlighten all of us today. Thank you so much for joining us. Ma'am, your slide is visible. Can I request you to kindly make it full screen and then we can go ahead with the talk, ma'am?
Okay, good. Whew. Are you seeing it?
Yes, ma'am, it's perfect. Full screen and you're audible loud and clear, ma'am. Please go on, ma'am. Thank you so much.
Okay, so today.
And just to interrupt, ma'am, before she starts, we see the total number of participants here, which is 19, but that is only the faculties. And we have almost 870 plus participants in this webinar. So thank you everyone who have joined us through this webinar. And I'm sure it's going to be an enlightening session, 2 talks and the panel for all of you. Thank you, ma'am. Jolly, ma'am, please go on.
Yes, thank you very much, Priyankur. And I will not talk about all the other dignitaries here because I will murder their names. So all seniors, protocol observed, thank you for coming for this very important presentation and important PH. And allow me to say that you cannot manage it alone, and I'm building on what has already been said. You are not an octopus, but we say even octopuses have one head, sources on each deployment target at a time. The rest, they put it on hold until. So this in mind we go along. That PPH is not a lonely journey, it's teamwork. Oh, it's not going. Yes. So I will not bore you with a lot of epidemiology and data. You know that many women are dying from PPH every year. And thing, especially in low resource and middle income. We know that it is treatable, yet for mother's life, saving inventions are known. Women, they must, if we access this level skilled attendance, it may be it. And this happens all over the world. To do management, you need access to other emergency obstetric care services like provider training. They must have the skills, so they have to get updates. The drugs must be available. The support, supervision, and mentorship has to be done. The research. Recently, I was in Hyderabad for ICOG, and the researches, the innovations.
Is there a problem with the audio?
Are you not hearing me? Hello?
Yes, ma'am. Ma'am, now
You're
you're
not
audible.
hearing me. Oh, sorry.
Yes,
so
ma'am.
I'm talking about multiple bundles and different bundles. Why? Because we can't say we have only one bundle at health facility. And I will say, what is a bundle? They are different. They are, when you look at that, you see different bundles, but together they will work, or they work to achieve one goal, and that is PPH management. What are the bundles we have? I think India has seen this first bundle for quite some time, because you were involved in the Bill and Melinda Gates FIGO project for PPH control. And now we have the emotive, which WHO wants us to go with. And then there is another safety bundle, which is looking at not the skills for skills, but a bit of holistic, where they say recognize, have readiness. Of course, then you do the response, but you also use the data to do M&E. When you look at these bundles, as we continue, you'll see that the emotive is Melinda Stroke FIGO project response that we've been having, which was done in India, I think, for refractory. Then, and how is it different from usual care? You have 2 to 3, 5 interventions in one all the time, if you are going to say that you are doing the bundle. And when you're saying you are doing bundle approach, then you need to say, each time a trigger happened, then this, and this were done. Improves health outcomes. And it also improves the recognition of the PPH, and of course, standardization of management if you're doing each item in a bundle all the time. And of course, it improves multidisciplinary involvement and that is the e-bundle, the first response, the I believe if you want to have good outcomes, become sensitive, then the massaging the uterus, the your sleeve, tranexamic acid, IV, sometimes you instead of only IV fluids if you have severe PPH. And then you have escalation where but here, I believe this is for mainly the lower health facilities where they're not doing comprehensive treatment, comprehensive emergency obstetric care. So in E, I think escalation goes back to our original FIGO and partners bundle, where you go beyond the first bundle and you go to what they termed refractory PPH intervention. So as you can see, I've put those as bundles. You have 4 bundles, which you have to remember to do. And it's easier when you know the first one, I have the first 4, and then what are the supporting measures they are in a bundle. And then you know 1, 2, 3, and then you do them all the time. Then you the patient continues bundle, and then you again know the components. So bundling components becomes easier. And I think this will continue working even with the emotive, which caters for the first bundle. Here, this bundle approach for PPH care is looking at the 4 R's. Do you recognize? Are you ready to work? So readiness, you have all the things you need. I had somebody talking of the PPH kit. Do you have it? Do you have the standard chart? Is every item in there? So now you are readiness, but there are several things. What is in the response? How do you now treat the actual PPH that has occurred? Teams skilled. Are they doing the same things every time? In other words, standardized approach to care. Do they have the things to use, as in the standardized management of obstetric hemorrhage with the protocols and all that, so that all PPH occurrence is managed the same. And then, of course, the last R is reporting, and it adds on the systems learning. And here, that is why you look at the the clinical audits for PPH. So the bundles approach, we shouldn't say bundles approach equals emotive. No, we have skinning a cat. So the responses, the R's, also gives you a kind of an approach into PPH control. And I believe this is me, that using all the 3 doesn't really hurt. It only improves women's lives and controls deaths from PPH. So this is health system thinking, because we were, as I was talking, we are addressing mostly third delay. But how about the first and second delays? The delay at home, the delay in transit. So, and what does that mean to us? Recently, World Bank did studies in Uganda about maternal and newborn health. And one of them was looking at factors that hinder health workers to do their work. And I call it hindering management of PPH for today. And those were the issues. Mainly leadership. Service delivery was hampered by poor referral system, accommodation of government, functional theaters and infrastructure. In part of those 32 to 35,000 women a year. And it's like every day it's running. You run, you sometimes pick the babies. This one is pushing. So the functionality, if you say we want to do Caesar, you run to theater, but there is some other Caesar or some operation being done. So the ambulances, then the human resource, the skills, especially up country, medicines. So you can see all those financing. Financing is very big in low resource settings, of course. It was called the driver, or actually the oil that moves the engine, and the engine being the head system. So if you have no financing, I guess you have no not much to do about these other issues of medicines, stockouts, the human resource, getting the right human resource in the right place. So these are the factors. So is one bullet going to hit all of them? Not quite. So we need multi-level, multi-stakeholder approach if we are going to manage PPH. And as I said, leadership, you need the political leadership for access, especially from the hard to reach areas. The health workers, the interventions should be evidence-based, accountability. All these should go along the continuum of care, weaving in teamwork, multidisciplinary, but also sector. I liked what Hema said about anemia and how does it come? But then you remember an anemic woman will bleed. Anemia, yes, causes PPH. You are not going to treat anemia at delivery where we are treating PPH. You have to go back. Then you see what causes anemia. So you bring in agriculture and nutrition, you bring in environment, you bring in all these others. You bring in the other things to make sure that all these work together to control PPH. And I keep using the word control because it's not just there. So you need a good policy environment, the resilience of the health systems, the communities being able to respond to address the first delay in the first place. And second, where they need to look for money to do the transport, to pay for the transport. So communities, patients who have experienced PP care, PPH care, control, whatever care, when they got an event, maybe actually advocates to see how their experiences could help in prevention. I like engendering health, engendering PPH, engendering maternal health, focusing on health institutions who are teaching institutions, who are working on these women. How prepared are they? So you need that layered approach. Again, at multi-level, you look at those who are technical, are they to make sure things are in place? Are they doing their stuff? The enablers, the advocacy for funding, the coalition, all those different levels work together if harnessed to control PPH. So, in summary, individual level, family level, community level, institutional level, especially different institutions, but especially the health system response. And that is where all of us are who are on this forum. But we need to be cognizant that all those are important. Country level efforts, regional level, and global level. I'm glad to be in this global level webinar for reduction of PPH. So what do these do? At each of those levels, there must be commitment, either political, financial, stakeholder, whatever commitment has to be done. All these levels have to collaborate. And I say then they form networks of care. The FIGO president, Karen, calls it networks, what? Of nodes of care. Nodes of care. So, network nodes, that they are all nodes in different places, but together they form a coalition and a network that improves healthcare and reduces PPH. Improving equity. I've heard in India, the current chair of, I forget her name, the one who talked after Hema, that some places have higher mortality than others. So is it possible to get equity in accessing care? And then, of course, there is capacity development, there is community engagement, to engage communities to know that when you know you are far, you need to come nearer. There is surveillance and M&E after you say to speak everyone from those levels I've said that keep men. And of course, research and develop waived in all those levels to say, number one, why church needs some more and gentlemen, where did you lose me? I was concluding. I can't hear you, so I sign out.
Jaideep ma'am?
Yeah, hi. Hi, thank you, Jolly.
Hello.
Hi, it's nice to see and hear you. I mean, it's been a pleasure knowing you for all these years as a FIGO REI chair. And today, chairing this session on a wonderful, wonderful presentation, though your voice was breaking in between number of times, but, the messages were loud and clear. And I'm sure it has enlightened a lot of people who are hearing, because I absolutely agree with every word which you said. So it's not only, just commitment at one level, it is commitment at multiple levels. It's not only one bundle, it's multiple bundles put together. I remember, participating in the Lancet study for tranexamic acid, then all internal iliac artery ligation, skill development, all the drills which we have done over the years, but somewhere something is amiss. And I always keep on thinking, after doing so much at every level, what is it that is amiss? And the only thing which I come to the conclusion is that yes, the respect for women's lives is something which is going to be the topmost, because the moment we start valuing the life of a woman and her contribution towards humanity and families, societies, and nations, that is something which will help us in doing our best possible for saving their lives. And PPH is one such entity. And I feel apart from that, all these political wills or, social responsibilities, individual responsibilities, and the skill enhancement, drills which we keep on doing. And I've seen that, so much energy. Sheila Mane is here. So much energy, Preeti, and all of us have put in doing these skill enhancement drills. But till the people who are responsible for women's lives. It's not only the doctors or the support staff, but also the families. Still, they actually understand the individual responsibility which they have, and women themselves, they need to also take care of, because if they are anemic, if they are undernourished, if they are not going for regular checkups, I mean, it is the topic of the talk was absolutely appropriate. Multiple steps and multiple bundles, but there are, I think, thousands and thousands of steps which probably will take us ages to bring them together, but the efforts are all there, and the commitment from the societies and people is also coming together. And I think time will come soon, hopefully in our lifetime, when we'll be able to save many more lives, and respect many more values of lives in our times to come. So it was a wonderful, wonderful talk. Thank you so much for bringing it all together. Thank you, Priyankur, for forcing me to chair this session, because I have a train to catch. But it was an absolute delight. Thank you, and keep on doing the good work. We are very, very proud of each and every one of you whom I see on the screen today. Thank you for having me there.
Thank you, ma'am. Thank you so much for being there. Thank you, Jolly ma'am, for an elaborate talk on PPH bundles. I'm sure the delegates have taken a lot of take-home messages from your talk, and it was an absolute honor to have you on board with us today. Thank you, Jaideep ma'am, and thank you, Priyankur, for chairing the session too.
Thank you.
Yes,
Apologies for the bad network.
Can we move on to the next academic session? Can we have the slides, and please? This talk is by Dr. Muralidhar Pai sir, and our chairpersons for today's session, Dr. Ajay Mane sir and Dr. Obam from WATOC. Can we have the CV slides, please? Dr. Ajay Mane sir is currently the Vice President in charge of the Public Awareness Committee, sir. Yes,
Hello,
sir.
we can skip, please.
Yes. Our next chairperson is Akanian sir. He is currently a specialist OBGYN registrar, the Vice President of the WATOC, as well as the OMI Fellow and OWE Fellow too. I request Ajay sir to please introduce our speaker for today, Dr. Muralidhar sir.
Yeah, thank you, Monica, and thank you, Priyankur, for being here. I'm proud, privileged to introduce Professor Dr. Muralidhar Pai sir. He needs no introduction, but as a formality, I should introduce him for the newcomers. He is a Dean, Sikkim Manipal Institute of Medical Science, Sikkim, Professor of Obstetrics and Gynecology. He's a thorough academic personality. He's a 35 plus years of academics, 20 awards, 15 international fellowships, 200 plus publications, 2 textbooks, 700 guest lectures, and so many things which he has not mentioned in this, in this introduction. But he's a very great personality, very humble personality, and we know him since 25 years, at least me, and he's like that only since day one and till today. So, pranam to Muralidhar sir. And
thank you, Dr. Ajay.
I request you to please continue with your academic sharing of knowledge on all of us.
Okay. Yeah. So I will straight away jump into my topic. Thank you for inviting me for this great webinar, Dr. Priyankur and Dr. Monica. And I bring greetings from Sikkim Manipal Institute of Medical Sciences to all the chairpersons and the delegates who are watching this. There's a saying that when medicine fails, surgeons can deliver. So that's where I am today. I'm not going to touch about the medical management, the active management of third stage of labor included, and then the rest of it, the tamponades, the massage, the compression, and all those things. I will straight away jump to surgical management. First of all, how do you decide that now is the time that I have to think of surgical management? Number one, if it is after vaginal delivery, if the bleeding continues despite well contracted and retracted uterus, which means our medical management is already acting to its best levels, whether it is tranexamic acid or whether it is, the prostaglandins or ergometrin also, whatever it is. Now the uterus is well contracted and she is still bleeding. That's the time we have to, it's a common sense that we have to look for an extension of episiotomy. Sometimes the corner would have gone very high in the vagina, which you would have missed, and that would be the very much important bleeding point. Second one, the perineal tears. Usually we neglect this. We won't see whether the tear has extended into the rectum, sometimes the fourth grade, what we say, and that may be the bleeding point. Or there could be vaginal laceration as such, and that requires a proper handling. Or it could be a cervical tear. So it is very important for us to do that wandering method of checking every circumference of the cervix and see whether there's any tear. Now, if that is the only issue, we are actually lucky. So what all that we have to do is probably we have to explore thoroughly under proper light. Sometimes we may have to take the patient into OT because a very high tear cannot be sometimes seen in the labor room. Under deep general anesthesia, we may have to explore that and suture promptly, and that will take care of the PPH. So this is the simplest of all the surgical managements that we can think of. Suppose that's not the case, or let us say after vaginal delivery, uterus is not responding to our usual massage, that is one of the part of the active managements of the third stage, or compressions. There are a whole lot of compressive management, so I don't want to go into any of them. You can do bimanual compression and other compressions. And there are again many types of tamponade procedures, whether it is a balloon or whether it is the suction or many other types of tamponade procedures. Or finally, the medical management. The best of the drugs have been given. However, the uterus is not responding. It is flabby. That is the time we have to really think of following. Number one, inversion of uterus. If there is inversion of uterus, the uterus won't contract properly no matter what drug you give. Second one is, if there is a morbidly adherent placenta, again, uterus contracts, but it does not retract because there is definitely some placenta left behind. And number three, of course, is a uterine rupture, because apparently there is no vaginal tears, no cervical tears, but there could be a rupture, especially if you have given the VBAC, that is vaginal birth after cesarean section. Even sometimes a previous myomectomy scar silently ruptures during labor. You don't realize that. You realize only when she continues to bleed and none of the medical management is helping. So how to manage these cases? Let us take up one by one. First of all, inversion of uterus. If you are lucky that the inversion is just happening in front of your eyes and nothing has gone bad yet, then we can use a simple Johnson's management of inversion, which involves an immediate replacement by pushing back the fundus that has come out. Usually what we say, don't start with the fundus, start with the portion that is closer to the cervix and keep on slowly reducing the inversion. And finally, the fundus will pop inside on its own. But this is possible only if the patient is not in shock, PPH is not severe, but just the bleeding was there. But if the PPH was severe and patient is in shock, sometimes this happens, the whole uterus would have come out along with the placenta still stuck to the cavity of the uterus. So what we have to do simultaneous resuscitation, as well as we have to think of reducing this inversion under deep general anesthesia. That means we have to wheel in the patient to the OT. I'm skipping the portion of resuscitation, which is understood, which again comes under medical management. We have to take care of the fluid balance. We have to ideally ask for massive transfusion protocol, and we have to look at the other aspects. So I'm not going to talk in details of that. I'm sticking myself to surgical management only. So in the OT, again, you can try the same thing. You start with the portion that came last, push first, and the portion that came first will automatically go inside. After that, you can keep your hand inside until, of course, because when the anesthesia is given, the uterus is still flabby. And then, of course, slowly you can remove the hand and you can start giving oxytocin. So this method works in most of the simple situations. But if the situation is a little bit complicated, wherein, as you can see here, the uterus is totally inverted and a simple reversion is not possible, then you have to go to higher level of surgical management. First one is Huntington's method. So this is laparotomy. At laparotomy, can you see just the two fimbria can be seen? Rest of everything is gone inside. Probably sometimes even ovaries would have gone inside. So there is a rim at the cervical level, and you have to slowly dig into this, use multiple clamps, and slowly pull one by one. Again, the portion that went first will be pulled up, and finally you can use the Alice forceps and catch at the fundus, and you can get it out. It is not at all simple as I have been explaining. We have had several cases in Manipal, and it is really, really difficult. It's not that easy. We even ask an assistant to push the fundus from the lower side, the other side, vagina side. He has to wear a glove. Sometimes initially you may use a gauze and on the sponge holder and push it, and finally he has to push with the hand itself. If this simple pulling from above does not yield results, then you have to make an incision at this place. That's a posterior rim of the cervix. So you make an incision with a tight rim there so that you get some space to manipulate. You put your finger inside and then try to slowly push up the fundus. So rest is almost the same. Then, of course, finally you close the posterior incision that you have made. Well, nowadays people want to try different things. Elastic vacuum cup can be used on this portion which has gone inside, and we can slowly pull up step by step, and it happens. I have absolutely no personal experience with this particular method. Similarly, people nowadays, instead of laparotomy, they are trying this with a laparoscopy. I have seen only a couple of papers and couple of videos of this. I could not bring it here. Very rarely for an inversion, if nothing is working and if the patient is bleeding severely, like in other situations, hysterectomy is a last resort to save the patient's life. In a case of inversion, I have never heard or come across any such situation in my life, but this option also has to be kept in mind. So now I go to the second problem where the medical management has failed and uterus is flabby, and this time it is not because of inversion, but it is because of morbidly adherent placenta. Nowadays, most of the labor rooms have got ultrasound machine, and you have to make a quick confirmation that it is, yes, a morbidly adherent placenta. Suppose you have got time, patient is stable. If you want to reconfirm, you can do an MRI, but that's only theoretical. It is not practical. So you already know that the placenta has not been coming out, and by simple controlled contraction. So in any case, you have to take the patient to OT for either MRP under GA or slightly bigger procedure than that. So if it is a simple adherent placenta, then as I said earlier, manual removal of placenta, MRP, under deep general anesthesia is all that is required. Again, I don't have to explain the procedure here. You have to slowly go inside the uterus holding the cord, and then you have to slice out the placenta. Entire placenta has to be first separated, then entire placenta should be removed if possible, but sometimes you may remove it in piecemeal also. If this is not possible, that is the time we have to do a hysterotomy, because I'm talking about the BPH after vaginal delivery. So if it happens at cesarean section, it's a different issue. Already you have opened the uterus, so there it is not very difficult. You can manually remove the placenta because it is in your vision. But if it has happened after the vaginal delivery and simple MRP is not helping, then you have to resort to hysterotomy, followed by removal of as much as possible. Rarely, sometimes, in that PPP procedure, you will also remove a portion of the myometrium, but you should remember, if you do that, the next pregnancy, this uterus is going to be very weak, and this is got high chance of rupture definitely during labor. It can also rupture during the antenatal period. Now, if it is increta or percreta, ideally, we should not allow such patients for vaginal delivery at all. Nowadays, it is not at all difficult with the ultrasound experts, and with the high resolution ultrasound, we can easily diagnose increta and percreta beforehand. And if we diagnose, the best management recommended nowadays is a planned or elective cesarean hysterectomy at 36 weeks. But if it is a patient who came late in labor and she delivered vaginally, and thereafter you realize the placenta is not coming out, and ultrasound says that it is a increta or percreta, there is no point in doing hysterotomy and asking for more bleeding. You can straight away go for emergency hysterectomy. So now I come to the next portion, that is uterus has ruptured, as I said, a silent rupture or a rupture during the labor, which was maybe a case of previous cesarean section you allowed for vaginal delivery, or a previous myomectomy scar. So this obviously requires a tertiary care center, because we have to do peripartum hysterectomy. If you have time to shift the patient, you can shift using other methods of controlling the bleeding, but here tamponades and other things don't work because uterus has really ruptured. So it is better sometimes we try to tackle the situation even in a secondary type of hospital. In the first place, we cannot give VBAC in a primary care center or a secondary care center. It has to be considered only in a tertiary care center. Very, very rarely, a previous myomectomy scar can rupture even in a secondary care center. So if you have time, you shift the patient to tertiary care center. If you don't have time, you may consider there only. Whatever it is, there has to be an experienced obstetrician, because it's not like a routine hysterectomy. The uterus is big here and the tissues are very soft and supple. That's why we have to be careful. And the vessels are very, very large. There has to be a backup of senior anesthetist, urologist, and vascular surgeon, blood bank with enough blood products, ICU with ventilatory facilities and expert intensivist. All these things have to be properly counseled to the patient beforehand. And counseling also should be made saying that she may need ICU for a long time, and also future fertility may not be possible when you do hysterectomy. Of course, it goes without saying you have to take a consent. CBC coagulation profile cultures have to be done. Massive transfusion protocol is alerted. Central line with 2 large bore YB lines should be there. Catheterization, urethral, better to have a 3-way, and sometimes for the ureters also, because you are going to do an hysterectomy in a very large, enlarged uterus. Action items will be needed in the event of emergency hysterectomy. What are the differences, key principal differences or deviations between an ordinary hysterectomy in gynecology and a peripartum hysterectomy? Number one is, in emergency, with an unstable patient, clamping the uterine blood vessels take precedence over adhesive lysis, packing, cleaning, etc. The moment you open the abdomen, don't worry about keep on dissecting the adhesions and other things. You straight away go and clamp the uterine arteries first. Don't even bother to go in a stepwardly fashion, like I have to first clamp the round ligament and then the infundibulum pelvic ligament and all this. Straight away go and clamp the uterine artery. You may not cut it, but clamp and keep, so that the bleeding first stops. Similarly, like it's somewhat like what we do in case of ectopic pregnancies. We always were taught that don't waste your time in cleaning the peritoneal cavity of the blood. Straight away go and pick up the bleeding point, identify the bleeding tube and put 2 clamps and stop the bleeding. Then you can leisurely clean the peritoneal cavity. So pedicles can be rapidly clamped, cut and dropped. Don't waste your time in suturing that. The idea is that as quickly as possible, you clamp all the bleeders and remove the uterus, and then you have all the time on earth to nicely suture or doubly ligate all the pedicles. So the word is clamp, cut and drop. Okay, so now when the patient is hemodynamically stable, of course, obtaining adequate exposure and uterine traction will minimize the vascular and ureteral injuries. There you have some more time because patient is stable. Of course, now if the bladder can be easily pushed down, sharp dissection is better than just pushing with a gauze that will tear or lacerate the bladder. Every attempt should be made to identify the ureter, time to time avoid ligating it. That's why I said earlier, some people consider ureteric catheterization before going for emergency hysterectomy if you have urologist in the OT or in the next OT. Adherent placenta should be left in place as removal can increase the total blood loss. When the uterus itself is going out, what is the point in first removing the placenta and then doing the hysterectomy? It can be done together. Suppose you have done a cesarean section also, they say you go for a classical cesarean section, deliver the baby quickly, don't even have to close the uterus properly, just put the double clips on the uterine wall along with the placenta accreta or percreta or increta, you can do the hysterectomy. So now the tourniquet can be at any which way you like. You can put a myomectomy clamp also, but some of the surgeons will prefer a rubber catheter at the level of cervix. It temporarily shuts off the flow through the uterine vessels and it prevents massive bleeding from the accreted placenta. So general principles, no special technique as such, steps same as gynecological hysterectomy, but should be simple enough to perform rapidly. And leave as minimal dead space and raw surfaces as possible, especially in coexisting coagulopathy. Most of the time when the PPH happens, patients also will slip into coagulopathy. So this also has to be kept in mind. Then, of course, clamps are applied very close to the uterus. Don't go far away because as it is, everything is enlarged here and inadvertently you may clamp the ureters. Be close to the uterus as possible. This is one principle my professor is to say, even in gynecological hysterectomy, you can apply, except maybe in cancer cases. Other cases, better to be as close to the uterus as possible. If you want later, you can trim or you can shorten the ligaments so that there won't be wart prolapse. Don't include excessive tissues because you don't know. Sometimes there can be tear in those areas. Ligaments and vessels held by 3 clamps, 2 laterally and 1 medially, because if they slip, you are definitely in hell. Keep sufficient stumps so that your doubly ligatures are secure. Double ligation, simple and transfix, somewhat like as shown in this picture. So this is one of the hysterectomies. We did it in Manipal. Here, as you can see, the placenta is in situ. We didn't remove that. As you can see, after hysterectomy specimen also, placenta was in situ. Now, surgical management of atonic PPH. So it is not a case of ruptured uterus. Uterus is intact, but atonic despite giving medical enough management. For some reason, uterus is not responding. Maybe it's a covariant uterus, or maybe sometimes it is infected case, or whatever it is not responding. Maybe anoxia. Stepwise devascularization is what is advised in such cases. And second one is compression sutures, whole lot of them are there. Third one is internal iliac ligation. This is not exactly stepwise devascularization, but some people include it as a last step of stepwise devascularization, but I have kept it as a separate entity. And finally, of course, is hysterectomy. So let's take up one by one. Stepwise devascularization. What do you mean by stepwise? So stepwise means you all know the anatomy of this. I don't have to go into details of that. The first step is you go for only one unilateral uterine artery ligation at the upper part of the lower segment. So this is the lower segment, so as high as possible. So you can go for a unilateral. First, you can go for a unilateral ligation. But if the bleeding is not stopping, you can go for bilateral at the same level on the other side as well. Then if it is still not yielding the results, you go for a low uterine artery ligation at a lower level, as you can see here, which would include cervicovaginal branches as well as vaginal artery after pushing the bladder down and avoiding ureteric injury. So this is very, very important even if you go for a hysterectomy, especially the subtotal hysterectomy, because once you remove the uterus, the cervical portion does not contract no matter how much of uterotonics you give. And if it starts bleeding, you are definitely clueless as to what to do. It is definitely from a cervicovaginal branch of the uterine artery and a vaginal artery which you missed. So whether you are going for a stepwise devascularization where you are saving the uterus, or if you are going for hysterectomy where you are going to remove the uterus complete or subtotal, you should not leave behind cervicovaginal branches and vaginal arteries. That will be really, really dangerous. Then, of course, if it is not helping because, uterus has got lots of collaterals, the supply is also coming from ovarian artery, and ovarian artery, all of you know, is a direct branch of aorta. So people now think of putting unilateral ovarian vessel ligation. If that is not helping, bilateral ovarian ligation, that is at the anastomosis area. And then, of course, this procedure itself, once you do properly, it will be effective in 90% of the patients. Now, if all these things fail, you can straight away go for internal iliac ligation, anterior branch of the internal iliac ligation. Many of the obstetricians are now well versed with this procedure. If you are not, or if you didn't assist, or if you have not done yourself, you can ask the help of a surgeon or a specially vascular surgeon in this. In Manipal, sometimes we have the luxury of calling a vascular surgeon next door. So before that, we have a whole lot of options like compression sutures, and these B-Lynch now, I think virtually every single person knows. It has been done and dealt many, many times in many, many conferences. Full-fledged lectures have been given on that. So here it is just two simple vertical braces. Only problem here is that you have to incise the uterus if you are doing it in a case where after vaginal delivery, a intact uterus. Whereas if you have done it after cesarean section, already uterine incision has been made. So you have to go through and through and then come out, and this is a simple step. So uterine incision is needed here. That is the point. Whereas there is a modification by Heyman and Arul Kumaran where they say that there is no need to open the uterus or put an incision on the uterus, especially if you are planning to do this compression sutures after a vaginal delivery. So here it is simple two vertical sutures, and if you need, you can put a two transverse sutures at the junction of the cervix and the uterus, but of course above the bladder reflection. If you want, you can incise the UV fold of peritoneum and push the bladder down to be on the safer side. This is modified B-Lynch. And Cho sutures is of course multiple square sutures where the bleeding is very heavy. If there is placental accreta and things like that, you can put these kind of sutures. These sutures have been questioned. There is a debate. People feel that once the uterus contracts, these sutures will become loose and things like that. But they definitely have helped in a crisis. You don't know what to do. Either you have to keep on holding the uterus compressed for some time till it really contracts. Once it contracts, doesn't matter if the suture becomes loose. What is your problem? So because the uterus was not contracting, you put this suture and make the uterus tight. So that is the idea. So I personally believe that these sutures still have some role. If they become loose after the uterus contracts, doesn't matter. The uterus has contracted. Now the bleeding has stopped. So then there is a sandwich technique where compression suture are sandwiched. The uterine wall is sandwiched between the compression sutures, and inside the cavity, you put a balloon tamponade. So this is possible only in B-Lynch because in B-Lynch, you are not closing the uterine cavity, whereas in Cho sutures and other sutures, you are closing the uterine cavity. So here, what you have to do stepwise, first insert a B-Lynch suture, don't tighten it yet or don't suture it yet. Insert a balloon after that and fill it with 100 ml of the fluid. Then close the uterine incision, taking care not to burst the balloon, and then tie off the B-Lynch suture and finally inflate the balloon further if you want. So this is like the uterine wall is sandwiched between the balloon and the stitch. And then of course, internal iliac ligation. This can be done either before compression sutures or after compression sutures, along with stepwise devascularization or independent of that. So some people always go straight away to this instead of wasting their time in stepwise devascularization, because that itself takes a lot of time and patient keeps on bleeding at that time. They say, we'll straight away go to internal iliac ligation because they feel they are confident about that procedure, I agree with them. So there is nothing like hard and fast rule. There is nothing like you have to do this, 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 this. There can be done sometimes simultaneously. Sometimes you can do some things first, depending upon your expertise and depending upon your availability. And finally, of course, it is hysterectomy. And hysterectomy, I have already dealt in detail. Here, I will just repeat few salient points: clamp and drop technique, double ligatures for all pedicles, and do total hysterectomy wherever possible. And where not possible, you can at least take care of the descending cervical and vaginal arteries. So I think I conclude that, and thank you very much. And I will be happy if there's any doubt or anything I want to clarify.
Ajay sir.
Thank you, sir. Thank you, sir. So basically, Monica, now we have witnessed one Foxy focus on PPH presented by only one person. It was such a nice lecture with a very to the point, clear-cut instructions in minimum words. He has explained all the things. So, sir, thank you very much for the very nice deliberations. Sheila Mani ma'am is here. I request Sheila ma'am to give, because she is a PPH lady.
Yeah, good evening, ma'am.
Good evening. I think, yeah, very nice deliberation, as it's a very big topic, surgical management. And our previous speaker, that is FIGO PPH chair, I think Dr. Jolly Behza, has already told us what is important, So PPH management starts once it is diagnosed, wherever it is, And if we are in the institute, it should not land up with surgical. That is our main motto. And the team should be trained to handle all this. I think your presentation on acute inversion of placenta, because many youngsters might not see these cases nowadays, which we have seen. Okay, so what is important is the management of third stage of labor is very important, because I experienced it 1 year back where it was mismanaged by a resident and a midwife, and then I had to go and manage that case. So it is very important that the third stage is managed properly, and I think WHO and FIGO has given clear-cut guidelines for that, which are very, very important. Okay, and that is why in WHO guideline, in SPA guideline, when it said that control cord traction, so then they said that you can wait till the separation of placenta, because they found that many untrained people, they were trying to deliver the placenta and they did not know the proper guidelines. And the blood loss was comparable. I mean, even though we wait. So traditionally, we used to wait for separation of placenta. Still, we can wait, but deliver by controlled cord traction. And I think surgical management, I must say that all of you and all of us have really geared up. Maybe in certain situation, as you said, internal iliac artery ligation, you may require. So one should have a task force or a team if we are managing obstetrics, wherever you are, that when you face an emergency, somebody should be there in the vicinity or who is there to come and help you, because one person cannot handle sometimes. And saving mothers is at the end of the day very important. So I think what we look forward is 0 deaths due to PPH. We can't prevent PPH, but at least let us look forward to 0 deaths so that we can manage it properly. Thank you.
Yes, thank you, ma'am. Thank you, Sheila ma'am, and thank you, Pai sir, for the great deliberations. Over to you, Monica.
Yeah. Thank you, Ajay sir, for chairing the sessions. Thank you, Sheila ma'am, for an excellent feedback. And Pai sir, your talk was as elaborate as it could be. Thank you so much for having accepted our invitation in spite of your busy schedule. Thank you so much, sir.
Thank you.
I would also like to acknowledge that we've also got 3 credit points from ICOG for this webinar. And I would like to thank Dr. Parul sir and Sarita madam for acknowledging the program and giving us 3 points. So all the delegates will also really get that. I would now invite Dr. Shatabdi Dey to please carry forward the session and introduce our moderators and expert panelists for the panel discussion.
Thank you, Monica.
Can we have the slides, please? Yes.
Very good evening to everyone. After those two very brainstorming talks by Dr. Jolly and of course by our very own Dr. Pai sir, we now move on to a panel discussion. We hope that the panel discussion will be as exciting. We have two very dynamic moderators with us. We have Dr. Sheila Mane ma'am and Dr. Aruna Suman ma'am as our moderators for the day. And our expert is Dr. Firdausi Begum ma'am, all the way from Bangladesh. Can we have the slides, please, Sayan? Yeah, Dr. Sheila Mane ma'am, we just heard her. Ma'am is currently the DNB faculty at KCG Hospital, Bangalore, as well as the ICOG Governing Council member and president of the ISOPOP Society. She is also the president of the Bangalore Menopause Society, and she has held various positions in FOXI over the years. Welcome, ma'am. Our next moderator is Dr. Aruna Suman ma'am.
Okay.
Dr. Aruna ma'am is the professor.
We can proceed.
Yes, ma'am. Yes, ma'am. And HOD at a medical college at Telangana, Government Medical College at Telangana. She was also the AICOG Hyderabad 2024 Organizing Secretary and Practical Obstetric Committee FOXI member. Welcome, Aruna ma'am. Our moderator is Dr. Firdausi Begum ma'am from Bangladesh. Can I have the slide, please, Sayan? Yeah. Ma'am is the professor and head of department at the Department of Obstetrics and Gynecology at Ibrahim Medical College and Burdem Hospital at Dhaka. Ma'am is the president of South Asian Federation of Obstetrics and Gynecology, SAFOG, also the president-elect of the Obstetric and Gynecological Society of Bangladesh. We are really looking forward to your inputs, ma'am. Very warm welcome to you for as moderator for the session. We have 10 dynamic panelists with us. Shan, please have get the slides. Yeah. Our first panelist is Dr. Varsha Lahade, ma'am. Shan, slides, please. Yeah, Dr. Varsha Lahade is the president of the Nashik Obs-Gynae Society as well as the zonal coordinator for AMOX. She has been the past joint secretary of IMA and national faculty at Gestosis Committee. Welcome, Varsha, ma'am.
Thank you.
Our next panelist is Dr. Bharti, ma'am, our very own Bharti, ma'am. Ma'am is the president-elect of Kasoga. Ma'am is also the South Zone coordinator of the FOXI Public Awareness Committee and the director of the Indian Red Cross Hassan. Welcome, Bharti, ma'am. Our next panelist is Dr. Raghavendra, sir. Dr. Raghavendra is the director of Infertility and Fetal Maternal Unit at Sunrise Hospital, Kanagad, also the executive director in ARMC IVF, Mangalore. Welcome, Raghavendra, sir. Our next panelist is Dr. Arnav Pai. Dr. Arnav is a consultant at DY Patil Hospital, Navi Mumbai. He is also the Indian representative to WATOG. Welcome, Dr. Arnav.
Thank you.
Our next panelist is, welcome. Our next panelist is Dr. Radha Madhavi, ma'am. Ma'am is the founder, president of Tiruvannamalai Obs-Gynae Society, as well as the director of Rajam Multi-Speciality Hospital and Rajam Institute of Paramedical Sciences. We welcome you, ma'am. Our next panelist is Dr. Mangala Gadwal, ma'am. Ma'am is a consultant obstetrician and gynecologist at GPV Super Speciality Hospital at Raichur, as well as the president of Raichur Obs-Gynae Society. And she brings us over 21 years of expertise in women's health. Welcome, Mangala, ma'am. Our next panelist is Dr. Manjula Raghunandan, ma'am. Ma'am is the medical director and senior consultant at Sri Srinivasa Nursing Home at Nakkarel, Nalagonda, as well as she was the Honorable Secretary of Nalagonda Obs-Gynae Society since 2018. And she's held various positions in FOXI over the years. Welcome, Manjula, ma'am. Our next panelist is Dr. Lohita, ma'am. She is a senior specialist at District Hospital, Chikmagaluru, and a practicing gynecologist for the past 26 years. Welcome, ma'am. Our next panelist is Dr. M. Chandra Ponnuswamy, sir. Sir he started the first laparoscopic and IVF center, ma'am. Sorry, she started the first laparoscopic and IVF center of her district at Namakkal. She has been gold medalist in her studies, and she has various affiliations and awards to her credit, and life member of various FOXI societies. Welcome, ma'am.
Thank you.
And our next panelist is Dr. Nirmala Devi Bachoti, ma'am. Ma'am is attached to Sri Nakkahala Lakshmi Hospital at Elleru at Andhra Pradesh. She has been the past secretary and the present president of Elleru Obs-Gynae Society. Her special interests are social service and music, and she has various awards to her credit. Welcome, ma'am. I think now I'll hand over the session to Sheila ma'am and to Aruna ma'am for carrying out the session.
Is Dr. Firdausi Begum has joined? Are you sure? Is she there?
Just a second, ma'am.
Dr. Firdausi Begum?
No. Can't see her, ma'am.
Yeah,
we'll
just
try
see,
to contact her, ma'am. We'll just try.
Yeah.
Yeah.
She is an expert today. We'll go ahead with the panel. Okay. Can we
Yes,
have
ma'am.
slide
Try to
show?
contact.
Yes, ma'am. Thank you for the opportunity. Public Awareness Committee FOXI with PPH Committee FICO and BETOC. I thank Dr. Priyankur Roy and Monica Umbardan for this opportunity. And it's my privilege and I feel wonderful to moderate along with our PPH lady, Dr. Sheila Mane, ma'am. And thank you, ma'am, for all the guidance and for making such a good PPT also. And let's go about this panel. Ma'am, I would like you to give the introduction.
Can we have a slideshow?
Regarding PPH.
Slideshow, Aruna.
Ma'am, I put it in a slideshow.
It is not showing everybody, whole screen.
Are you able to see the screen?
Yeah, but the whole screen is not seen. I mean, you have to enhance.
Ma'am, the screen is visible. You have to make it full screen.
Okay. Let me share it again because I have the full screen.
No, it was correct. You have to just click on that icon. Yeah, exactly.
Yes. Is it fine?
Not coming.
Not it.
It's loading. It's loading.
Here I'm able to see the full screen, ma'am.
Anyway, I think we'll proceed. Okay.
And press F5.
You have to press M5, Aruna.
Okay, 1 minute.
Youngsters can guide us. I don't know.
Yes, I did it.
Yes.
I did it, ma'am. This is what I'm able to do.
Okay.
There's a little problem here, I think. I'll stop sharing and I'll share it again.
Anyway, thank you all. I think Dr. Priyankur has really have panelists from South and West, I think. And it's nice to see that we should really share. I think it is nothing going to be any questions or anything. I think all of us have to share our experiences and our whatever practices we have. So all of us, we know that the obstetric bleeding is different than any other bleeding, and we always face a lot of problems whenever the patient starts bleeding. And still the maternal mortality due to PPH is about 25% in our country. And that is, even though we have reduced our maternal mortality to, I can say, in most of the states, like if we are talking about South and West, it is 2 digits. But still, you know, PPH is a preventable cause. Okay. So if it is a preventable cause, we must prevent it. And as I already said, that we should look forward for 0 deaths due to PPH, and that should be our motto. And for that, all of us, we know that anemia plays a very important role. I think we'll proceed, Aruna. Go to the next slide.
Ma'am, sorry to interrupt, just if I could say one thing. Akinene, he was a little stuck with some thing in his hospital, he said. So he has joined now, ma'am. So he could be a part of the panel if you don't mind. I mean, he is the Vice President of ATOG. So if it's possible, we could include him in the discussion.
Yes, yes. May I know his name, Priyank?
Dr. Akinene Ubom. Dr. Ubom, you can call him maybe.
Dr. Ubom. Okay.
Yes.
He's from which country?
He is from Nigeria, ma'am.
Okay.
Sure. Thank you, ma'am.
Okay, Aruna, next slide.
Yes, ma'am. Yeah, this is the case, ma'am.
No, the slides.
Slides are not changing and it's not full screen also, ma'am. So Slides are
No,
not
I
changing.
don't know. There is little.
Or you share it with the organizers?
Yes, I did, ma'am. It is in the group. It is in the group.
Just see, Priyankur, somebody can
Yes, ma'am.
download and play. Here there is resume slideshow. Huh? Yeah, it's changing now.
It's changing?
Yes.
Okay. This is
Go
the
back,
case,
go
ma'am.
back, go back. Yeah, fine. Okay, go to next slide, please. So we have a case which was unbooked, 26-year-old, Gravida 3 para 2 with 2 live children and normal deliveries earlier. She was admitted in active labor and delivered a healthy baby weighing 3.2 kg. Of course, active management of third stage of labor was done and placenta was expelled after 10 minutes, which is usual. And in the next few minutes, the nurse noticed a sudden gush of bleeding PV. Uterotronics drill was done, uterine massage started, bimanual compression done. Still the uterus remained flabby. So, and there was no IV line in situ as patient had come in active labor and delivered immediately. Next. So Dr. Varsha, now this patient has started bleeding suddenly. As we always say, you know, it is very unpredictable. How do you quantify blood loss?
Yeah. Good evening, everyone, and thank you for having me here. First of all, when this patient started bleeding, the sister, am I audible?
No, not clearly, Varsha.
Okay. Now?
Also, I'm in.
Okay, we can hear you, but if you can hold the mic nearer. Huh.
Yeah, I'll do that. So, first of all, clinic is very important in this patient. You have to see the vitals of the patient, and the quantification of the blood loss has been done. Looking at the soakage pads, which she has soaked the pad underneath her buttocks. So visual inspection has to be done first. Then the dry and the wet, as well as weight of the dry as well as wet mop as well as the underpad has been done. And after that measure it, and then if the half of the pad or mild soaked pad approximately is 550 ml and the fully soaked pad is around 100 ml. There are multiple methods.
Aruna, can you change the slide? Aruna.
Yes, ma'am. I did.
No, it's not moving again.
Quantity of
you have to change. You have to click on the slide in the
called as Safai mat, where the squares are being counted.
It will move.
Bharti, can you see the slide change? No.
So accordingly,
on the regular, not in slideshow.
You can quantify the blood loss.
Not in the slideshow. I don't know. There is little problem.
It's not in the slideshow. So you can measure the weight as well as dry and the wet in kgs and convert it into ml. So
okay, now I would like to know. Yeah, now it is a slideshow.
Now it's fine. Now it's fine.
Yeah. So Varsha, if you meant to say that quantitative assessment of blood loss, I mean, we should know the standardized method to assess the blood loss, right?
Yes, madam.
So we should weigh the drapes earlier and then weigh it later. But and then we should also see that how much is collected in the jug, you know, which is kept in the bucket if it is a normal delivery. So direct measurement of blood is also equally important, which the blood which is collected. And then we have to see the way, and then the measured that collected blood, that will be the total blood loss. Okay. So in this patient, they just tried to. Now I would like to know from all the panelists, because you know everybody is not used to this. Are you people are doing this routinely?
Yes. Drape we use. Yes. And we have this underbed and all.
So quantitative as well as the thing is done. So next slide, please. I think some lot of problem. So this was the thing in this case. The weight of the wet mops was 575. Dry weight of 10 mops was 200 grams. So The weight of the blood loss was 375 ml and total volume in the drape was 700 ml. Volume in drape before placenta removal was 100 ml. So the measured blood loss was 600. So the total blood loss was around 975 ml. Now, next slide, please. So why it is important? Because most of the time what happens is we always try to underestimate the blood loss and here we miss the bus. So it is very important that we get used to, as Dr. Varsha was mentioning, that you have to have this type of chart in your labor room where you have already weighed the MOPS, so everybody knows that. So it becomes easy, but we have to practice it. So what was done was, as IV line was started, patient expelled a big clot and her blood pressure was 80 systolic and pulse rate was 120 and shock index was 1.5. And then she received injection Carbopros 250 microgram intramuscularly. Next. Arnav, yeah, go back. Okay, this is for Bharti. Bharti, can you tell us about shock index?
The shock index is the maternal heart rate divided by the systolic blood pressure, which gives you the index of shock, and it is an index of the hemodynamic instability and the amount of blood loss that she has had with the hypovolemia. So in normal situations, it would be 0.5 to 0.7 would be the ideal shock index. But in this particular case, her systolic blood pressure is 80. Her heart rate is 120. So 120 divided by 80 is almost more than 1.5. So this means that the shock index is high. The patient is in hypovolemic shock, and it gives us an index that we have to start moving in the fast mode to hemodynamically correct her, stop the bleeding, and try to not push her into irreversible shock, try to act very quickly. So that gives us an indication. It's very simple, the heart rate divided by the systolic blood pressure.
Yeah, thank you. Actually, the importance of shock index is, if we look at the classification of the clinical stages of hemorrhagic shock, you will find till stage 2, your patient's vital parameters, not much change is there. And there only the problem arises because we diagnose the PPH in a little later stage. But if we calculate the shock index, we will, because before the patient goes into metabolic acidosis or the triad of hypovolemia, hypothermia, or even the coagulation failure, we should diagnose it early so that according to shock index. Now they say once the shock index crosses 1.2, the patient has already lost 30% of blood load. The another way, next slide please. The another way is rule of 30. Even we can also use the rule of 30 where there is a fall in systolic blood 30, increase in pulse rate, output less than 30 ml per hour, respiratory rate more than 30. That itself tells you that patient has almost lost 30%. So clinical assessment of blood loss is equally important as well as the quantification. Now, yes, Dr. Arnav, things to do the golden hour, if you can quickly tell us now. I mean, it is very important, yes.
Yes, ma'am. So number one is to call for help. The older strategy which was used was the hemostasis strategy. But to summarize it in short, to call for help. Also the airway breathing and circulation assessment. So the main parameters during a resuscitation pathway must be done. 2 wide bore cannulas must be secured to be able to deliver the most amount of IV fluid during that time. Also, collection of the blood at the same time of IV installation for investigations and cross-matching. Catheterization must be done so as to just get an idea of the urine output, which would be reduced as the shock increases. Also, palpating the uterus, massage, and cervico-vaginal exploration to rule out any traumatic causes of PPH. Also, the uterotonics and mechanical methods have to be started. If that does not control the PPH, then the surgical methods can be done. Also, if she's hemodynamically unstable, ICU or HDU admission has to be considered, and proper counseling and consents must be taken, and the relatives must be kept in the loop.
Yeah, so we have the preparedness is the key. Okay, this was the PPH box, but all of us will have the cart in labor room round where whatever is required has to be there. Everything kept ready, and what is important is stop the bleeding. Okay, and you as a leader there, you will have to have a helicopter view of the situation. Communication is the key. When you are giving instructions to the nurses, you should take their specific name and tell. Otherwise, next slide please, Aruna. Otherwise, what happens, there will be a chaos and the relatives can notice that. Now, Dr. Raghavendra, do you think
Yes,
would
ma'am.
you have given tranexamic acid to this patient? If so, when and how?
Ma'am, when the patient is actively bleeding, we definitely can give. That is within within 3 hours of PPH, it is the most ideal time to give. And you will give, give it immediately, and you can ideally give around 1 gram, which is given over 10 to 20 minutes. And if the bleeding is continuing even after you finish the first infusion, you can give an additional 1 gram.
Next slide, please. Yeah. So this was the women trial which happened in 2017, which all of us know that that it reduced the death due to bleeding by 19%. So now Jhpiego says that we have to, as you mentioned, give it as early as possible, and also we can repeat. Now the thromboembolic events is just a theoretical risk and which there is no need. Anybody is aware of any more trials? If you can, I mean, just would like to know. Any other trials with tranexamic acid? We have again Women 2 trial, okay, which is coming up. The Women 2 trial is for anemic patients particularly, because we know that the fibrinolytic activity is more in anemic women as the viscosity is more and the blood does not clot soon. So we can give 500 milligram intramuscularly to the anemic patient. And that will also help that trial. I think the results will come soon. And TRAP1 and TRAP2 trial, where it is given prophylactically to all vaginal deliveries 1 gram and 1 gram prophylactically to all cesareans. And Dr. Raghavendra, your experience of using tranexamic prophylactically during cesarean. Next slide, please, Varuna. I think you are muted, Dr. Raghavendra. Anybody? Yes, Doctor.
Yeah, we do use, madam. We immediately, as soon as the baby is born, we start giving the tranexamic acid infusion.
Okay.
That's how it was suggested.
Yes, yes.
In cesareans, I use it prophylactically just before the incision. I give 1 gram of tranexamic acid in 100 ml of normal saline. We give it even before the skin incision. And in high-risk vaginal deliveries also, I do give it soon as the baby is born, before the delivery of the placenta, we do give it. But of course, in case of PPH, that is one of the first line of defense, along with oxytocin. We do use tranexamic acid, and it definitely has given us good results.
Yeah. So all of us are doing that. The trials are happening. That is TRAP1, TRAP2. Next, please. Next slide.
And one more important point is this should be given within 3 hours after birth.
Yeah,
whenever we diagnose PPH.
Should not be. See,
slowly an infusion. Please do not give a rapid transfusion of tranexamic acid. It can cause hypertension.
Hypertension. Now
Next
it's a
slide.
regular
Next
practice.
slide, please. Yeah.
To use tranexamic as a, it's a regular practice now. It's to use a tranexamic acid as a prophylaxis and as well as a
That's what
treatment.
I said. No, TRAP1 and TRAP2 are for prophylaxis. Okay. Yes, Dr. Lohit, do you think anti-shock garment to this patient, would it be useful?
Yes.
Anybody? Dr. Lohit?
Dr. Lohit, are you there?
Anyway,
Yes,
Madam Chandra Pundaswamy or Devi?
Yeah, I can answer this.
Yes.
It controls the bleeding through direct pressure. After transfusion of blood in an upward direction, it can give. Ball in abdominal segment applies focused pressure on the uterus. Circumferential pressure on the lower half of the body reduces the total vascular space. Vital organs get increased blood supply and oxygenation. Stabilizes the patient during transport. These are the advantages of using.
I think FIGO guidelines clearly mentions the use of anti-shock garment. Okay. WHO has also mentioned. So I believe that all of us who are participating, that they are used to and they know that how it is really. It is not only for the periphery to transfer the patient. And we have Dr. Radha from Tamil Nadu. And I know it is available in every government hospital. Even in tertiary centers, my experience that we can use it. Even we are waiting for the blood to come. Next slide, please, Aruna. Or even we are waiting for the OT to get ready. Okay. Aruna, would you like to take from here? Yeah.
Yes, ma'am. Yes.
Yes, Dr. Lohit, do you have any personal experience of using anti-shock garment?
Hello, can you hear me,
hello.
madam?
Yeah.
Yes, madam. While transporting the patient who are in shock to the higher care center, we are used, madam.
Okay.
Yes, madam.
Yeah.
It is helpful.
Yes, it is very helpful, and I think all of us, every obstetric unit must have it, which is easily available, and it really reduces the mortality by 50%. Okay, I think Varuna, you can take from here.
Yes, ma'am. Dr. Nirmala Devi, question for you.
Yeah.
Would uterine tamponade help? If so, how would you use it?
Definitely it will help, ma'am. A Bakri balloon or a condom tamponade can be used. And while filling the balloons, 2 fingers are held in the vagina below the cervix to prevent the balloon expulsion. And cervical sutures sometimes have to be occasionally applied. And the external catheter should be tightly fixed to the proximal medial thigh so that the pressure is given on the placental site and the bleeding.
Which type of balloon do you use in your institution?
Condom tamponade, ma'am.
Okay.
Yeah, I think most.
So can you tell us about the success rate? Yes. Yes, ma'am.
Yeah, you have to insert through the vagina into the cervix and then expand it.
I think all of us are used to use the condom tamponade because most of the places they don't have a Bakri balloon, and it is very, very dynamic also because it can just take the shape of the uterus. Then we have Chhattisgarh balloon also. If we don't have condom, we can use the glove also. Okay, and
yeah.
I think
and the success rate in uterine atony.
Yeah.
Yeah, in success, uterine atony is around 87.1%. In vaginal deliveries, it is about 87.0%. In placenta previa, 86.8%. And in the cesarean deliveries, it is 81.7%. And in placenta accreta spectrum, it is around 66.7%. So overall, this is going to definitely help.
Basically,
yes,
all
very
these
successful, and it will
methods-
prevent hysterectomies also.
Exactly, exactly.
Dr. Radha Madhavi, how good are suction cannulas in atonic PPH and what is your experience?
Good evening, all the learned audience and the office bearers of this thing. I thank all of you for giving me this opportunity. I will take 2 minutes. Actually, I was very scared to use uterine suction cannulas. Initially, in Tiruvannamalai, I'm in a very rural setting where people are already anemic. I was very scared to use uterine cannulas, and once I've started using it, it is so very useful. It has literally replaced my choice of balloon tamponades and all. And negative pressure is created within the uterine cavity. It is very physiological, and it is very useful in atonic PPH. It is introduced into the uterine cavity through the vagina. The cannula is connected to suction and negative pressure 700 mm from our usual suction machine. It is applied. When blood is sucked out and the bleeding stops, that suction is maintained for 30 minutes. And I just leave it for a few more hours and then take it out. The cannula is taken out. When we are taking out, that most important thing is we have to gently remove the cannula. You can't just pull it out. Because of the negative suction, all the uterine tissues, that base of the uterus and cervix, luckily,
sucked into the canal. Yeah.
and you will just damage it. And it is a wonderful invention, and I would like to thank Samartha Ram, literally saving many people because of his cannula.
So this can be used during cesarean section also.
Also,
we have,
yes,
two
it can be
cannulas,
used.
shorter
Yes,
cannulas.
yes, yes.
See, there are 2 different cannulas for cesarean section and a short one. For vaginal delivery is the angulated one. So
Yes.
it is directed upwards, so it doesn't come in a way of suturing episiotomy.
Exactly.
And it is, as Dr. Radha said, I have also used it, and where we anticipate PPH, RH negative mothers, it really helps. Removal, we have to be, it is a little tricky. Yeah. Thank you.
Once you get to use it, ma'am, like carbetocin, once you start using it, it is really wonderful.
Yeah. Next question. Yeah. Aruna.
Yes. Dr. Mangala Gadwal, what
Yeah.
about Carbetocin? What
Yeah.
is the experience and what is the advantage you have seen?
Good evening, madam. Thank you for the opportunity. Especially, I'll thank Dr. Bharati Rajshekar, madam, for giving me opportunity. So, Carbetocin usually it is a wonderful drug. Nowadays, we are using it. We are using it regularly. It is mainly heat stable, especially useful in areas where cold chain transport and storage is not feasible. Carbetocin 100 mg is given slow IV or over. Easy to administer, long duration of action, but its efficacy is treating rather than preventing the uterine atony. Is not well documented. So it's clinical studies Carbetocin versus oxytocin. So Carbetocin 100 mg IV Carbetocin can be given for oxytocin 10 units IM can be given. But outcome is amount of blood loss in 24 hours primary PPH and massive blood loss, need for additional uterotonic therapy, blood transfusion, adverse effects. These are all can overcome with Carbetocin.
Yes, these are the results that you can see.
Outcomes. Outcome, primary see, results with the outcome with Carbetocin is primary PPH, blood loss, immediate blood transfusion, need of additional uterotonics, and average amount of blood loss is very less compared to oxytocin. No significant side effect, madam.
Okay.
This
Can
is
you tell us about the champion study, champion trial?
Yeah, champion trial. This is a heat stable Carbetocin versus oxytocin to prevent hemorrhage after vaginal birth.
Yeah, and we are proud that it happened in Karnataka only, even though KLE Institute conducted it. So
yes.
the inference was it is non-inferior. And I think
yes.
all of us are using, I think all the panelists will agree,
yes.
right?
Yes.
Very few contraindications.
All of us are using it.
Yes. So
Yes.
there is a recommendation, but it is only for prevention till today. That we have to remember. Yeah.
Yes, ma'am.
Next. Yes, Aruna.
Coming to the case, we are going back to the case. So what next is to be done? What did we do? Blood and blood products were arranged. Condom catheter was inserted for tamponade, removed after 18 hours. Anti-shock garment was applied. Patient was monitored for next 24 hours. General condition has stabilized gradually. And we have the newer drugs for the PPH, controlling PPH. What are the newer drugs that we should remember? The tranexamic acid and Carbetocin. Older but less utilized methods to combat atonic PPH is balloon tamponade and suction cannula. NASG, which can save lives while all these are being implemented, should be remembered. These are the learning points today. And Dr. Anna, can you tell us about the E-Motive trial of WHO? How is it important?
Yes, ma'am. So the WHO introduced this emotive trial as a PPH bundle. So just to manage PPH in a stepwise manner. So the E stands for early detection and trigger, as we discussed earlier, with a visual representation to just detect how much blood was used. So we use a calibrated drape. And the milestones for this blood loss are 300 and 500 ml. Also, we observe the blood loss, the blood flow, the uterine tone every 50 minutes and make a chart. Also, the blood pressure and pulse is monitored for the first hour, and it's documented on that same chart. The trigger criteria are blood loss more than or equal to 500 ml or 300 ml. The M stands for massage of uterus, and this is done until it's contracted at least for a minute. Then the O stands for oxytocin drugs, which is the base drug, which is the 10 international units of IV oxytocin in 200 or 500 ml of crystalloid over 10 minutes, followed by a maintenance dose of 20 international units of oxytocin in 1000 ml. And this is over a 4-hour period, this maintenance dose. Then the T stands for tranexamic acid, which is the standard 1 gram dose in 200 ml of crystalloid over 10 minutes. The IV stands for IV fluids, in addition to the infusion, so as to just increase the blood volume. And the E stands for examination and escalation. So we must ensure that the bladder is empty, evacuate clots, and check for any tears to rule out traumatic PPH, and escalate this PPH management to surgical procedures or any other intensive procedure if the bleeding doesn't stop. Also, certain implementation strategies are there of how to implement this emotive trial. So the audit newsletters are a very important way. Also, midwife and doctors must implement this change at their private nursing homes. Also, the trolley or carry case must be ready with all the effective medication and devices to be used. And of course, training must be done for all the midwives, doctors, and obstetricians that are present. Yes, ma'am.
Yeah.
Thank you, Dr. Arnav. Ma'am, coming to the second case.
Excuse me, can I add something, Dr. Arnav?
Yes.
Yes, please. Please,
After
Dr. Chandra.
seeing everything regarding management, everything, retrospectively, what I feel is this is patient third gravida. Though, as we said, prevention is better than, and we can expect any case can go in for PPH. So
Yes.
she's third gravida. Once she enters into the labor room, we have to start the IV. Right? Yeah. Then active management of third stage. Immediately, after the delivery, we start them on oxytocin drip. And in my experience, what I feel, when you get a sudden gush of blood, usually we think of the retained product or any cotyledon of the placenta. So we have to look the placenta, whether it has come out. Usually atonic will
examine the placenta.
Yeah, examination of the placenta. And you have to, in retained placenta only, mostly this sudden blood will come. Whereas in atonic, there will be blood coming. And in traumatic or peritoneal, there will be continuous oozing. So we have to anticipate all these things, and that too, people in rural area like us, we'll be very cautious, and we don't get, and we are answerable to the people.
Very true.
Yeah. So retrospectively, we think, and this case, what we learned is we have to be careful and we have to prevent, and at every probability of going into PPH, we have to see into that. That's my thing.
Yes.
Thank you.
Very nice, Dr. Chandra Ponnuswamy. And there is a role for aortic compression also in this case, whenever there is gush of bleeding before calling for help. Ma'am, Sheila ma'am.
Yeah. So this was again a busy night. A primary gravida delivered a 3.8 kg baby with an episiotomy. And there was another delivery, and a junior resident was asked to suture. 2 hours later, there was a call from the labor ward that the patient was complaining of severe pain, lower down, and wanted to push badly. That is after the delivery. Next. So I think sometimes we know that this vulvovaginal hematoma may be there, which can press over the rectum. So yes, Dr. Manjula, when can an episiotomy cause PPH? Yes, it is traumatic. Yes. Dr. Manjula? Can we have Dr. Manjula?
Dr. Manjula, are you there? Or Dr. Varsha, you want to take up?
Yeah.
When can an episiotomy cause PPH? Yes.
Yeah. Am I audible? Yeah. In this case, there is a junior resident who has sutured the episiotomy. He might have not sutured it properly, or the bleeder might have been missed. And because of that, the patient had vulvovaginal hematoma. That is, and the hematoma, you will not realize the amount of blood loss there immediately. So the vital has to be seen during the post delivery to check the vitals of the patient. So in this case, it's almost and 10% of the women undergoing the episiotomy may have hematoma, and the approximate blood loss may be near about 300 ml.
So I think that is why
so
now
which type of episiotomy is better?
Is not.
Yeah, so medial lateral is the best.
Medial lateral episiotomy.
Slide, please. Next slide.
The best, madam.
Dr. Sheila, can I add on to this?
Yeah.
Yeah, as you said, I think we have to have a judicious use of episiotomy rather than a routine necessity of an episiotomy, as the general practice is, especially in India. And of course, rather than the mediolateral episiotomy, the midline episiotomy is safer, though it bleeds initially, because there are not much varicose veins in that midline. But you have to be careful that you give proper perineal support. And whenever there is an episiotomy, I think we have to train our younger obstetricians that a good light and expose the vagina, angle of the vagina properly, and try to hold it with either an Alice or a Babcock's, and try to take a good bite of the apex. Because most often it is because you miss the apex, or there are some veins which retract after the episiotomy, and we don't catch hold of those veins, and they start bleeding following the suture of the episiotomy.
Yeah, so we know this. So Dr. Chandra is there, I think. Yes, Dr. Chandra.
Yes.
Vulvovaginal
How can you manage the
hematoma?
vulvovaginal hematoma?
Yes, regarding this, no, when we were in PG or junior residents, whenever they complained of any pain in the vagina, what we think, and maybe she has got pain in the episiotomy area, and we'll be seeing the uterus, it will be contracted. But in contrast, she will be going for low BP, vital signs will be bad. So in that case, we have to see the episiotomy area. It was our experience. Then in case that will be hematoma. So, but if the hematoma is small, we have to observe it for another 2 to 3 hours. If it is not increasing in size, we'll leave it as such and we give some proper antibiotics. Whereas it seems to be increasing, what we will do here, no, just we cut through the episiotomy sutures and we look for the retracted vessel. That is the culprit there. So we have to catch hold of the vessel and suture it. Then again we put the episiotomy sutures. Sometimes if you are unable to suture, catch hold of the vessel, we the secondary suturing means we will leave it quite some time for better. Maybe we are wrong, I don't know, but we'll leave it without completely suturing it. Just pack it and we'll leave it.
I think, yeah.
Then
I think we must, do you think we must do rectal examination, because sometimes outside it may not be visible? As you said,
yes,
no,
definitely.
Yeah.
You have to do
That is very important.
so that it will hit the vaginal epithelium and it will show the muscles and all. Then we can catch hold of the vessel. Yes.
Yeah.
In vulvovagina, can I add?
Yeah, if it is a large
please.
hematoma, then we have to go for laparotomy only, because we will have to treat it that way. Yeah.
For the larger hematoma, intervention is must. The smaller you can.
If it is supralevator, we have to do laparotomy. Next slide. Next. So role of
Any novel methods of tamponade for vagina and uterus, Dr. Varsha?
Yeah, there is a one novel balloon. They have two balloons. One is in the uterus and the other is in vagina, because in vagina actually the weakest part where we don't reach is the apex of the vagina. So in that case, where if there is some laceration which we are not able to suture, then the lower tamponade gives a pressure effects, and it is to be kept for at least 18 to 24 hours, and that gives a beautiful pressures in vagina as well as in the uterus. So that's a very novel thing we can
I think
use.
if we don't have that and the uterus is well contracted, we can just use the condom tamponade for the vagina, or we can pack the vagina. No, we should have a big pack. We can, not the ribbon gauze, but a big pack. Yes, Aruna, you can proceed.
So what happened was 2 hours later, patient complained of abdominal pain and her vitals were falling. Emergency ultrasound uterus displaced to the right side with the suggestion of the broad ligament hematoma. So this is the broad ligament hematoma. And Dr. Bharati Rajshekar, can you tell us how to manage this broad ligament hematoma?
Laparotomy.
Bharati?
I think she has left, I think.
I think Dr. Chandra, you can take
Anyone
it.
can take
Anyone, or Dr. Radha Mahesh.
Hello?
Yes.
Yeah.
Bharati.
Yes.
Dr. Bharti, we are talking about supralevator hematoma, how to manage this.
Yes, she'll
Are
be
you
having
there?
only abdominal symptoms. And
you have to make an immediate, or even other surgical specialties. And once you do the laparotomy, give her a liberal incision and then make necessary arrangements for the massive transfusion protocol to be in place. And then if she is hemodynamically stable, of course, you could do a conservative management. But this particular lady is continuing to deteriorate. So you have to explore, it is a prudent to have a urologist with you. So either you can, so that we can have assistance so that we do not damage the ureter when we are exploring or when we are trying to evacuate the clots there. And then we will have to do a so stepwise uterine artery ligation if necessary, uterine artery ligation and stepwise pelvic devascularization. See that, take care that you do not injure the bowel, bladder and ureters, and put a compression, and you can wait. And if the bleeding persists, then of course you will have to go for either an internal iliac ligation, or if you have facilities, you could always go for it, arterial uterine artery embolization. But however, this is not a very easily available option for most of us. So ideally it would be, we could go for a stepwise devascularization, internal artery ligation, and in the worst scenario, we may have to compromise the uterus by doing a hysterectomy.
Can I add, Suman? Aruna? Can
Yes,
I add?
yes, please,
Yeah,
please,
in the
Varsha.
patient,
Yes.
when the vitals are failing down, first of all, you don't go hurriedly to the surgical thing. First of all, you have to stabilize the patient. So you have to have a blood in your, the patient has to be shifted in operation theater. Before, in the operation theater, the patient has to be stabilized and then go for the surgical intervention. Otherwise, the patient deteriorates on the table. So exploratory laparotomy is very important in this patient. And of course, the surgical help you would be needed for the
multidisciplinary approach.
Yeah.
Multidisciplinary approach is important. It's not only surgery.
And this has to be evacuated immediately.
Yes, okay. The next question is to Dr. Raghavendra Prasad. Ma'am?
Aruna, can I add, in all these cases,
Dr. Chandra, yes.
Informed consent is very, very essential, because in our hurry to save the patient, we'll be proceeding, we'll be doing the all procedures, but in that informed medico-legal perception and medico-legal point of view, informed consent with the patient as well as attender is must one. So we should not.
And concern regarding hysterectomy also, you have to explain to the
we'll be dealing with the laparotomy, everything, no, for evacuating the hematoma. So that is essential, because they have come for a normal vaginal delivery. So we face all this because we are in a private institution. We don't have any backup and all. So we have to deal with all these things, no. So informed consent is a must, and
ideally, this is right. As Chandra ma'am is saying that it is correct. But when there is a dying emergency, whatever you do good, whatever do good to the patient in a good faith, it exempted from the consent. But everything has to be informed to the relatives and to the
and the documentation is also very important. Dr. Raghavendra Prasad, any newer instruments to tackle PPH vaginally? Can you think of any newer instruments?
Yeah, we have the transvaginal uterine clamps. When I think it is introduced, one was by Dr. Professor Piley. Those clamps, when used, do help a lot in arresting of the bleeding. And the other one is one transcervical paracervical clamps, which are placed. Again, these are the two things which are available right now for us to tackle uterine clamping. To tackle the PPH from vaginal without the tackle vaginally.
Yeah. I think once the patient is bleeding, our main motto is to arrest the bleeding. So we may have to do all other interventions, like we can put balloon tamponade, we can put anti-shock. But to control the bleeding, these clamps will be useful. And I think this was Dr. Ramlingapa's clamp, which is also not now easily available, but Dr. Piley's clamp is definitely available. Yeah, next.
Yes.
Next slide, next. Yeah, I think we discussed traumatic PPH, and all of us, we know that we should be ready. because active management of third stage of labor is not going to prevent traumatic PPH, and tranexamic acid role play. There is a role of tranexamic acid in traumatic PPH too. Actually, according to WHO recommendation, till 2012, it was only for traumatic PPH, but now for any bleeding. Okay, within 3 hours, that is important. Next slide. So case 3, she was referred due to abdominal presentation, diagnosed during ultrasound. Aruna, you would like to take? Yeah.
Yes, ma'am. Sonia, 33 years, Gravida 3, Para 1, Live 1, referred to our hospital due to abnormal presentation, diagnosed during an ultrasound at 27 weeks. Previous LSCS done for CPD. The trans-abdominal scan showed a viable fetus with appropriate biometry and normal amniotic fluid, while trans-vaginal Doppler images suggested the diagnosis of placenta previa accreta. So this is how the picture looked. And in previous cesarean delivery, when and how will you rule out accreta? Dr. Lohit Kumar, can you please take it?
Yes, madam. Can be done by the ultrasound, like even in the second and third trimester. It is best diagnosed in the second and third trimester. If the placenta previa is in patient with previous cesarean section, one should look out for the following features: multiple vascular lacunae within the placenta, loss of normal hypoechoic zone between the placenta and the myometrium, decreased retroplacental myometrial thickness, that is less than 1 millimeter.
So how helpful is MRI in establishing the extent of placental adherence?
Not much. It's unclear whether MRI improves the diagnosis of PAS beyond that achieved with US alone. Accordingly, MRI is not the preferred recommended modality for the initial evaluation of possible PAS. This is mentioned in ACOG volume 132, number 6, December. So the MRI findings.
What are the MRI findings?
The MRI findings suggestive of placenta accreta include lower uterine bulging, heterogeneous placenta, dark intraplacental linear bands on T2 weighted images, can provide information on depth of invasion in placenta percreta, may be particularly useful in the diagnosis of posteriorly located placenta. These may be the findings in MRI, but primarily MRI is not used for the diagnosis. The USG is.
How can we suspect bladder involvement? Dr. Radha Madhavi, how can we suspect the bladder involvement?
First indicator for bladder involvement is hematuria if she is not having urinary infection and she is having hematuria. Cystoscopy is not so useful because it's difficult to do and not available everywhere. A good ultrasound itself, most of the times, is fair enough to diagnose. We have to diagnosis should be confirmed by MRI, and urinary analysis should be negative for blood. Cystoscopy, ma'am, it is your thing.
Yes.
I think
so. What exactly was done in this case?
Anterior. Placenta has to be lower and anterior. That's the first prerequisite.
You should have high index of suspicion.
Okay.
Yes. Yeah. I think if it is low lying from the first trimester, previous section, anterior, we have to tell the sonologist to look for it.
Yeah.
Any placenta which is low lying and anterior, consider it as adherent placenta in a previous cesarean and be prepared. Otherwise, even though ultrasound said that it was not adherent, we have still found that the placenta can be adherent, and then we can face problems. So MRI mainly for posterior, and I think we have a infertility specialist here. I think in most of the IVF cases, because if it is associated with endometriosis, we see posteriorly adherent placenta. Okay. So even if, it is posterior, in that case, it is better to do a MRI. Otherwise, yeah. Next.
How will you prepare for her for cesarean section? Dr. Mangla Gadwal?
Yes, ma'am.
How do you plan? What is your plan?
Yeah, first of all, most important is consent. Consent for both surgery also and for hysterectomy also. And main thing is counseling also. And regarding complications of the surgery, then multidisciplinary team like urologist, and we may need vascular surgeon, but remote places like us, our Raichur and all, we don't have such this thing. So IV access, two wide bore needle like IV cannulas will be in secured, and blood products maybe make it ready like PRBC, then platelet transfusion FFP, then Foley's catheter Foley's catheterization and the ureteric stents, and uterine incision we should see the uterine incision, and drugs. Usually to control the drugs, we have all the list of the drugs, and emergency drugs also being ready. Then anesthesia. So even anesthetist depends upon the anesthesia, like general anesthesia may be the most probably may help us, like it is feasible. That post-op care is also very, very important. And these patients are like very risky. So we have to follow up properly at least for 24 hours. Then choice of anesthesia is general anesthesia, madam. Because of extensive surgery and massive hemorrhage and prolonged operation theater requirement.
So what are the techniques that can reduce the blood loss during Akrita surgery and to avoid a hysterectomy? Dr. Manjula? Or anyone can take up.
Yeah, and this placenta Akrita situation, you have to first be prepared.
Manual removal of the placenta.
Secondly, the incision, the abdominal incision has to be vertical, as well as the uterine incision has to be classical. So, and when removing the placenta, try to remove the placenta, but if it is really adherent, do not touch the placenta and try to leave it. These are the precautions you have to take intracesarean. And
Ma'am, Sheila ma'am, you have to give us few take-home points. Shall we remove the placenta if it is Akrita?
No. See now anybody wants to contribute?
No, we cannot.
Yeah. See, you have decided whether you are going for conservative, and there are different methods. But it is not so easy. But I must tell you now, slowly, as we are seeing more and more cases of adherent placenta, most of the people are trying to do the conservative management. Now, the conservative managements are now the first thing what we should do is, like, conservative will be tailor-made. You have to have a proper patient, not for all the patients. Okay, saving patient's life is more important. So after you remove the baby, first you ligate the uterines. You can ligate the uterines because that will help to reduce. Even we can also ligate the ovarian. We can also ligate the ovarian artery or put a ligature with an infant feeding tube in the infundibulopelvic ligament, which you can release it later. Okay, because even if we have ligated uterines, there can be a bleeding from the ovarian, and ovarian is directly from aorta. Yeah, so directly we can do that, and then we can find out whether now there is a triple P method. But these are all very few selected cases where you have to do an ultrasound intraoperatively. You go above the level of the placenta, and then you try to do. So in a selective cases we can do, and I must tell you that there are very few people like Dr. Ashwath who has done this modified triple P procedure. Dr. Bellat from Belagavi is also doing, but your case selection is very important. If we are able to remove the placenta, even if few bits of placenta are left, it is better to leave. We can put a balloon tamponade, we can pack the uterus, we can do stepwise devascularization or internal iliac artery ligation, correct the hypovolemia. That is the conservative line of management. And I think we already discussed about that. Yeah. Compression sutures will not go in detail, as Dr. Muralidhar Pai has already spoken about it. But in lower segment, I think we should take a cervicoischemic suture, because most of the time it is a lower segment bleeding.
Yes.
So a transverse compression suture in the lower segment. And I think we know that B. Lynch in 1997 introduced a suture for the lower segment in cases of placenta previa, which controls the lower segment PPH. You can go on YouTube and see. It is beautifully described. Okay. So we can do that, take that suture also for the lower segment, which can control the bleeding. And meanwhile, when you are managing the patient, your patient is hypoxic, even upper segment will also start bleeding. So we may have to take compression suture for upper segment also, for the lower segment also. So stepwise devascularization. Yeah. Internal iliac artery. Yes.
This is the tourniquet that is used.
Yeah. Next.
Ma'am, 1 second. Can I just add? Have
Yes.
all of you heard about the Gunishila stitch?
Yeah. I know
Yes,
about
yes,
it.
yes.
So, but you know,
Yes.
I mean, you have to be very careful because there are vessels at the, because that is like that periara suture where you take 2 vertical and 2 transfer, nothing else. Like
Have
that.
you used it, madam?
No, I have used only vertical. I have taken 3 compression sutures because there are such big vessels, you know. You really get scared going there, and which causes hematoma. So I have done uterine ascending, descending, and ovarian. Okay. Yeah. I think,
Dr.
yes.
Chandra
Yeah.
Ponnuswamy, tell us about the triple P procedure.
Yes, actually, as
The
Dr.
simple 3
Muralidhar
steps.
explained,
Yes.
explained very well. The triple P is one is the perioperative location. During the surgery, we see the placental position, and delivery will be done in the incision about the upper border of the placenta. Though maybe it will be upper segment, but no need to worry about it. So it should be, incision should be in the upper border, above the upper border. Then devascularization, stepwise maybe. Then when we expect all these things, replace occlusion balloons in the both internal iliac, that we need vascular surgeons. So with the help, prior, we have to plan the surgery and we do it previously, prior to the surgery. Then if it is not getting separated, placenta is separated means we remove along with the myometrium excision and then suture the myometrium. So that particular area.
Dr. Varsha?
Yeah.
Yes. Varsha, can you tell us about the sandwich procedure which is carried out in case of atonic PPH or during placenta accreta surgery?
Yeah, placenta accreta surgery. Am I audible?
Yes.
It's a combination of external method and internal methods of combating the bleeding of atonic PPH. It is done during cesarean section. The Foley's catheter is used and the bulb distended up to 90 to 100 ml. It is retained for 12 hours. It combines with uterine compression sutures as well as a tamponade and should be considered before hysterectomy. It is safe and more effective. So it's a dual method where you use a tamponade as a compression and a sutures along with it.
And this can
Dr.
be
Bharti?
Compression sutures, if only V-Lynch will be of useful here because they
Yes,
don't get others cavity. Other sutures which involve the cavity, so we cannot use the tamponade.
Okay. Dr. Bharti, what is your experience with aortic compression?
Well, aortic compression will be definitely does help, especially it gives us some time when we are shifting the patient in a dire emergency. Before just providing some firm, you ask your assistant while you're exploring, you ask your assistant to use the fist and give good compression on the aorta at the level of N2, L3, where the just above the division of the aorta. So that will give you some time and maybe to some extent reduce the pressure, so the amount of bleeding may reduce, and the time to organize the operation theater before you shift the patient, either for a balloon tamponade or even for a laparotomy you're going to do. You can definitely use this the aortic compression with your fist in cases where we don't have the facilities. Of course, Dr. Paley has come up with a very good aortic clamp, which I don't have any personal experience, but I have seen Dr. Paley demonstrating how we use this aortic clamp. That is when we open the uterus, when we do a laparotomy, and then when we are trying to sort out the issue as to where she is bleeding from and what are we going to proceed next, we can clamp the aorta there for transitorily, so that the aortic pressure reduces and we are able to find out the bleeders, or we are able to identify the spot, and then we can go ahead with either internal iliac ligation or any other hysterectomy we're going to take place. So this Paley's aortic clamp can be used when we open, but before we open, when we are shifting, definitely this does help us to reduce the amount of bleeding before we take her up for any other procedures.
Yes. And before calling for help, we can use this.
Yes,
Yes,
before
Dr.
calling an
Mangala.
I have done it, because when the patient is bleeding profusely, you have to ask one of the resident to do that till you arrange the blood, till you do all other methods. See, arrest bleeding is the motto here, you know. You have to see to it that she doesn't go into that hypovolemia and DIC triad. Okay, fine. Next.
So when we do this, the femoral artery pulsation should not be palpable. That is the mode.
Sorry.
Now coming to the uterine artery embolization, whenever the cath lab is available, we can do it.
I think it is
And
also helpful
Raghavendra
for
Prasad.
a uterine artery for traumatic PPH also. Even we can avoid laparotomy. Yes, Dr. Raghavendra, you have any experience?
No personal experience, but from what I've seen, I mean, you should have the facility to do it. And the patient should be stable. You should have tried everything else before going for these therapies. And usually they normally perform an angiography to identify the abnormal site and use gel form or N-butyl cyanoacrylate just to arrest the vessel. I mean, that is how they do the embolization, but it is done in tertiary centers where, I mean, you need the help of an interventional radiologist also.
Yeah.
So,
Unless and until the center is
yeah.
geared up, and there
Yeah.
are chances of failure also, particularly in adherent placenta, because there are so many collaterals. It is not
Yes.
only the embolization of one vessel. So many collaterals are developed. So, you know, where the facilities are not there, hysterectomy remains the resort, because we have to
safer option.
We have to save the mother.
So Dr. Lohit Kumar, what
Yes, ma'am.
precautions will you take while performing a hysterectomy?
Yes, madam. Like, first of all, you should take the informed consent, arrange for the blood and blood products, and then it should be better done in the tertiary center where the multidisciplinary approach is available. While doing hysterectomy, clamp should be applied close to the uterus, and then there is something called the safe site approach. Then usually you do start the hysterectomy from the where there are no adhesions, then deal with the adhesion site, that is to free the bladder and all. It is done later. You can try what is called as a retroperitoneal hysterectomy. You start doing hysterectomy from the posterior side, cut the uterus from the vagina from the posterior, cervix, separate the cervix from the vagina posteriorly, then go release the adhesions. It's better to avoid this one, like injury to the bladder.
Okay. What is your experience in leaving the placenta in situ? Is it advisable? What is your experience?
No, madam. I don't have any experience leaving the placenta behind. I don't.
Sheila ma'am,
I
can we
think,
leave the placenta in situ?
that situation arises if you have a placenta percreta.
Percreta.
Because if you are not prepared, you know, the bladder will open, the patient will bleed torrentially. So even sometimes it is better to do a two-stage surgery. Here you just tie the placenta and leave it there, okay? And very rarely we have seen that the placenta, because once the pregnancy is terminated, the vascularity comes down. Then you can take up her for surgery after 48 hours, have the urologist, the vascular surgeon, because you may have to repair the bladder. At least, you know, the blood loss will be less, but the sepsis also to be infection, we have to take all the precautions to see that the patient does not bleed. In Bangalore, I remember one or two incidences where they have done this way. But I mean, percreta, once it is there, it really becomes difficult, only in that case. So, as we said, multidisciplinary approach. Next.
And what was done in this case at cesarean, placenta tissue was manually removed and hemostatic sutures were applied in the area of the bleeding at the site of the placental blood using 10 Vicryl. Later, a B-Lynch compression suture was inserted and a Bakri balloon inserted into the uterus through the hysterotomy site and filled with 100 ml of normal saline. Finally, the abdomen was closed using a regular technique. The blood loss was 2000 ml, 6 units of PRPC, 6 units of FFP, and 1 apheresis. Everyone mute, please.
Bharti, unmute, please.
Mute.
Sorry, mute, please.
And platelets were transfused. So 1:1:1 ratio. The post-operative course was uneventful, discharged on 7th day in good condition. That was really successful. So what are the learning points from this case? Pre-operative preparation and proper informed consent, reserve blood and blood products. Senior obstetrician should be always available with good anesthetist, AMTSL, acute blood loss assessment,
not to give oxytocin, not to give.
Yes.
Not to
In
give
this case.
oxytocin, yeah, because what will happen, the placenta
yes.
will get separated partially.
Okay, ma'am.
And then it will cause more bleeding. Okay, at
So
least
before handling, we can do the uterine artery ligation. So stepwise devascularization, IV fluids, crystalloids till blood products arrive, replace blood products and low threshold for hysterectomy. So this is how you have to plan. Dr. Nirmala Devi, what is hemostatic resuscitation and how does it improve the outcomes?
This is the hemostatic resuscitation is a new concept that mainly involves 3 aspects. One is limited early aggressive use of crystalloids and consideration of permissive hypotension. 2, early administration of fresh frozen plasma and platelets with concomitant packed RBC, achieving a ratio of 1:1:1. And then 3rd, early use of recombinant
factor 8,
activated factor
7. Sorry.
So these are the things. And what do you mean by the hemostatic resuscitation? How it is done is aggressive crystalloid resuscitation is avoided. Why? Because to prevent the hemodilution and early clot dislodgement secondary to the increase in blood pressure as a result of volume expansion by giving the aggressive crystalloid solutions. And then prior to surgical control of hemorrhage, permissive hypotension with systolic blood pressure between 80 to not to the normal, that is up to 120 we don't take, from between 80 to 100 mmHg may be optimal to limit the ongoing blood loss. Thirdly, the rationale for early administration of fresh frozen plasma, platelets and packed RBCs in a ratio of 1:1:1 is to achieve hemostasis earlier does decrease the total number of blood products given at a later stage.
Can we be quick and talk about this massive transfusion protocol, just the guidelines, Dr. Radha Madhavi?
Yes, ma'am. If the loss of 1 blood volume within 24 hours period has occurred, we start the massive transfusion protocol, and loss of 50% of blood volume within 3 hours, loss of blood at a rate of more than 150 ml per minute, the woman becomes pale, sweaty and diaphoretic, her pulse rate exceeds her systolic BP, and the blood she is losing is watery and does not clot. It is very important to watch this point. Having people to help us is the most important thing. The senior consultant will notify the blood bank and the MTP is activated in the ratio of 1:1:1. That is, RBCs is to plasma is to platelets. After the first 4 units of packed RBCs, coagulation tests are done and sent, and further transfusions are based on the reports. Once the patient is stabilized and the bleeding is controlled, blood bank is informed and the MTP is deactivated. Help. Call for help.
Yeah.
Call for help.
I would like to add something here. As we say about massive transfusion, the first coagulant factor which goes down is the fibrinogen. Okay. So nowadays even fibrinogen is available. And if the fibrinogen is available, it should be given. At least the level of fibrinogen should be 200 milligram per deciliter. Fibrinogen is available as a 1 gram vial, and I have used it now, and it really helps to reduce the amount of blood products given. So I would like to add here now the newer protocol is Aruna 1:1:1:1. Okay, and that another one is cryo. That another one is cryo, because if we delay giving, because when we give FFP, the FFP does not have that much of fibrinogen. But if we give 10 cryos, at least we are giving, by giving 10 cryo, we are giving 1 gram fibrinogen. Okay. So it should be 1:1:1:1, so that the patient will not go into DIC. Yeah. And what FIGO says, the earlier speaker already pointed out that you should not allow the POP to clot. So not too much of IV fluid. And the FIGO says you should do damage control resuscitation. The damage control resuscitation is a combination of resuscitation, surgical interventions with the purpose of restoring hemostasis and normal physiology. That means you should not allow her to go into for acidosis. That is there. So if she is bleeding,
Okay.
I mean,
Yes,
there are incidences I must share with you. We have given 30, 40, 50 transfusions. Don't hesitate. Go on giving. Even we have given 80. A case of APLA, abruptio, delivered bleeding. Okay. And now we have fibrinogen also. One of the patient, we gave 4 grams fibrinogen. Along with anti-shock, along with balloon tamponade, all that was happening. 80 transfusions given, fibrinogen given. On 4th day, patient opened her eyes. So what is there is, just go on giving, because unless and until you correct the coagulation factor, the patient will not stop bleeding. So you need a tertiary care center and a multidisciplinary team for that. Next.
KC General is
So
a
after
wonderful
every
place.
4th transfusion, we give calcium gluconate, right, ma'am?
Very important, very important. Yeah.
And suppose in cases of PPH that go to court, in what situation is the doctor accused in negligence? Dr. Mangala Gadwal, this is important.
This PPH is nightmare for every gynecologist. It's very fast, furious. And so at that moment, we are very scary about that moment. But at the same time, we have to be alert about the legal aspect also.
So document.
So why is it happening? What are the factors that are taken care of?
Awareness of the doctor, inadequate action of omission, and lack of poor communication with the patient's attender, and improper documentation. So consent is
I would like to,
Summary. Sequence of non-operative and operative interventions for control of PPH. Promptly assess the success or failure of each patient. If an intervention does not succeed, the next in the sequence must be swiftly instituted. Indecisiveness delays therapy and results in excessive hemorrhage. Lethal combination, dilution coagulopathy, severe hypovolemia, tissue hypoxia, hypothermia, and acidosis. This will make control of hemorrhage much more difficult and will increase the likelihood of hysterectomy. Major morbidity from hemorrhagic shock and death. So for this, yes, ma'am. Yes, ma'am.
Yeah, Aruna, I would like to
So
just
we
add
need to
this
have
medical
frequent drills or frequent skills to learn the
I
skills.
just
We
wanted
need
to
to
add
have
this.
the drills.
Yes.
So the basic thing in the basic thing is the resources which has to be complete. You should have the checklist in the labor room as well as in the operation theater.
Yes.
Third thing is your preparedness. Your skills are very important, that you should upgrade the skills of your staff as well as yourself. And fourth, you should take the help of the people so that you don't. And first thing, whatever you take counsel the patient has to be documented. Whatever you document has to be informed to the patient. Fourth, every
Then go to the
event is
last
to be
line.
documented in the paper. Then about the drugs also you have to see that all the drugs are according to the checklist. These are things that the patient doesn't take you to the field.
Yes, ma'am.
Everything said and said, madam, when we go through that situation, all what we have discussed now will go for a toss, because half the time you'll be so stressed that you will not, you will be totally confused on how to manage, because when you are in a peripheral setup, it is always difficult.
I agree.
So in a peripheral setup,
You should call for more help. That's
yeah,
all.
exactly. That's what exactly.
Drill
And as you
skills,
said, the
ma'am.
facility readiness is important. So we need to have mock drills every 6 months to improve our skill.
Not
And this
to
is the
operate
book
other
written by
and placenta. Not to operate other and placenta in a periphery.
Correct,
Yes.
madam.
You have
Refer
to
immediately.
refer the case. But sometimes, unpredictable, the bleeding happens. You should have a tamponade, anti-shock, and you must shift the patient to HDU. You'll have to accompany the patient, resuscitative measures to be taken. I know it is a difficult situation. It's not easy. So this is one of the book which we have edited. It's a very small, easy book which you can read. And I also have the link on which is for the residents. Aruna, I would like to tell everybody, I would like to invite you to join our virtual PPH workshop with ICOG. on 27, 28
Yes, ma'am.
February and 1st March between 4 p.m. to 7 p.m. It's a certification course. So I will share the flyer with everybody and everybody can join. It's a ICOG initiative.
Yes, ma'am, definitely.
Yes, ma'am. Thank you so much.
Yes, ma'am.
That's a good.
Thank you
Thank
very
you,
much.
Sheila Mani, ma'am.
Thank you all. Yeah.
Thank you all the
ma'am.
panelists.
Thank
And
you,
thank
Sheila, ma'am.
Thank you,
Thank you.
organizers, Priyanka Roy and Monica Umvardhan,
Yeah.
for all
Yeah,
the
Thank you, Monica and
involvement.
Priyankur.
Thank you.
Yeah. And I think we had a guest, I think. Shall we ask him to say something? Dr. Obam, he's here from Nigeria, right? Dr. Obam, would you like to say
Yes,
something
yes.
now?
Akineni Obam. Is he there, ma'am?
Is muted.
Dr. Obam?
Yeah, he's there.
He's joined, ma'am, but he's on mute. Sir, can you unmute and please give your concluding remarks to the panelists?
Hello. Good
hello.
afternoon.
Yeah.
Good evening.
Yeah, good evening.
Yes.
Sorry,
Nice to see
I've
you.
been in theater.
Yeah. So we have discussed few cases. I came to know you're from Nigeria, right? Yeah.
Yes, I'm from Nigeria. Yes.
So if you can share your country experiences and about PPH, we would like to hear that.
Yes. So in Nigeria, PPH remains the leading cause of maternal mortality. It remains the #1 cause. And so it's still a very significant problem. So the experiences you have shared and the lectures you have given are very useful.
You must be having anti-shock garment in every facility. Do you have?
Sorry?
Do you have an anti-shock garment, a life wrap in every facility?
Yes, we have. Yes, we have.
Yeah, I think a larger study was done in South Africa only because that will definitely help, right? Yeah.
Yes, yes.
Yeah.
Yes.
So I hope that all of us, we really, we heard our FIGO person telling us that we have to tackle PPH globally. And I think all of us have to come together. Anemia is the another cause, I think, which should be taken very seriously because the women in low income countries are anemic. Okay. So I would like to just tell you that anemia, how it causes more bleeding is, it is increased heart rate. Okay. So the cardiac, stroke volume, then the viscosity is more. So the blood doesn't clot early. So it is a fibrinolytic activity, clot formation is not there. And the lamellar flow in the blood vessel is lost. The platelets are not there at the periphery to block the capillaries, and iron deficiency anemia. So these 5 things put together, it is not only the blood loss, the anemic patient cannot withstand and she bleeds more. So I think we heard a lot about tranexamic acid. Whatever it is, as I said, let us have 0 deaths due to PPH. Let all of us gear up. And, I don't know what will be the timing, Dr. Akineni. I can share I will tell Dr. Priyankur to share our ICOG virtual PPH workshop flyer. So if people from your country can also join, it will be very nice.
Yeah, thank you very much. That would be nice. Please, please do.
Thank you.
Thank you so much, sir, for joining in and for attending the panel discussion. Thank you, Sheila ma'am and Aruna ma'am, for moderating in this panel and the panelists for their excellent inputs. I invite Bharti madam to please officially propose the vote of thanks.
Dr. Monica, you want me to propose the vote of thanks?
Yes, ma'am, as a convener for the South Zone webinars.
Sorry. Yeah. I'm sorry, there is no light. I'm in my vehicle. Well, it was a very, very useful and deliberation with lot of inputs from all the panelists from different categories of hospitals, from rural hospitals to corporate hospitals. We had the input as how we can reduce the maternal mortality by managing postpartum hemorrhage very effectively and energetically using all the protocols and the bundles we have. And we had our FIGO representative Dr. Joyce, who was telling us that make use of as many bundles as you can. So, and Dr. Sheila Mane, the PPH lady, we are very proud because she belongs to Karnataka. She is very close to all of us. And as usual, Dr. Sheila and Dr. Aruna Suman have taken this panel in a very, very interesting way, covering all the case scenarios and all the management bundles that we have with us. So we are already running quite late. I thank all the Dr. Sheila Mane and Dr. Aruna for moderating the session. I thank the chairpersons and I thank all our panelists from the southern part of India who have participated in this program. And a big salute to Dr. Monica and Dr. Satabdi, who are always on their toes, doing all the work so energetically. I don't know where they get the time from and how do they cover their clinical work in this and manage family affairs. You have truly proven that women are multitaskers. And I thank all the participants who have joined in large numbers to know more about PPH, because every day we are learning something new. And by doing this, we are able to reduce the maternal mortality, though slowly and steadily, India is marching towards the sustainable development goals. So thanks to all of you. Good night and have a happy weekend.
Thank you. Now I have to pack my bags for Allahabad. IMS.
Okay.
Leaving
Have a
tomorrow
safe journey. Yesterday, what time are you leaving, Dr. Sheila?
Flight at 8 o'clock.
Now, tomorrow morning?
No,
Happy
tomorrow
journey,
morning.
ma'am.
Okay. Have a safe
Thank
flight.
you, Dr. Bharti.
Thank you, everyone. Thank you, Dr. Bharati.
Learned a lot.
Dr. Priyankur, Dr. Chandra, all the panelists.
Thank
so
you,
much.
Aruna ma'am. Thank you,
Aruna.
Sheila
Thank
ma'am.
you.
Thank you.
Thank you,
Bye-bye.
Monica
Good
ma'am,
night.
and all my
Good
panelists.
night.
Bye.
Thank you to FIGO committee as well and WATOC, as well as Corona Remedies for providing us this academic platform, and Mr. Syed Chaudhary for making all the changes from the technical end at the last minute also. Thank you so much, Mr. Syed.
Thank you once again.
Thank you.
Good night, everyone, and wishing you a
night.
very happy International Women's Day in advance, because we will be meeting in the next webinar after the Women's Day. Have a good
Monica
time.
ma'am, please share that ICOG link again.
Yes, ma'am. Once I'll take it from Sheila ma'am and I'll share it with you, ma'am.
Yeah.
Thank you
Okay.
so much.
Dr. Monica, thank you. Thank you for everything.
Thank you, Nandita ma'am. Thank you so much.
Radha, bye.
Bye.